One of the things that we attempted to do in the bill this year was to get rid of the waiting period, that 6 to 8 week waiting period if you're applying by mail. If you're a new patient applying by mail, you can use your paperwork as a temporary license, and that temporary license is valid Monday through Friday from 8 to 5, as if your problems will magically disappear on weekends. And there's no reason for it to be this way. The way that it is right now was set on the idea that the dispensary would call the Department of Health and find out if the patient had been rejected. But that's not the way it works in reality. If you call that number, they say, go look at the website. The website's available 24/7. So why the 8 to 5 restriction? So we're hoping that that can be taken away. Plus, it's only valid for new patients and not renewals. So if you're a cancer patient and you've been in remission for a couple of years and now your cancer is back, even if you're having surgery, radiation, starting chemotherapy again next week, if you're in a mail-only area, you have to wait 6 to 8 weeks to go back to your medical marijuana. And that's why we're asking for a medical exemption to the renewals are not allowed to shop with paperwork issue in here. And I'm not sure where you stand on that. I know my time is up. Thank you very much for listening to me. I've got a couple other things. It looks like, and I'm hoping that this is valid, that Part 1, Section 2 appears to now allow caregivers to test their medical marijuana. Let's make that happen. In places where there are no dispensaries because they've been banned, like Delta County and Grand Junction, having the caregivers, which is who we rely on to care for patients there, be able to test their medicine is a huge leap for us right now. Right now, this is banned for mysterious reasons that we don't understand. And we'd really like to get that taken care of, and hopefully we can proceed with that based on this ruling here. Thank you very much.
You're welcome. Thank you for being here today. Deb gave you an extra minute, plus I gave you the 16 seconds from Anna. So
I am forever in your debt.
Thank you very much for being here. Did you drive all the way over from Grand Junction? Oh, you did. Thanks for doing that. All right, staff, would you mind coming back up for us, please? And I'm sure the board will have some questions about the testimony that we heard just now. I will note, for what it's worth, that it seemed like, ma'am, Martha, how do you say your last name? Montemayor? Thank you. Montemayor. Montemayor. Thank you very much. That Ms. Montemayor had some comments that didn't directly reflect some of the changes that you've presented today. Is that right? So I'd ask you to keep your comments back to us specific to the regulations that we have in front of us today. And I'd ask the board to do the same. But what questions might we have for staff regarding some of the information that we received from our public testimony this morning? Dr. Stasio.
Yeah, so I had a question. So one of the indications is to utilize marijuana in place of opioid for, I imagine, pain control. So I can see a scenario, and this is where the dentist thing kind of comes in. It's like they had a procedure, has acute post-op pain, and the patient wants to use marijuana as a substitute. The issue I have is that how long does it take to get approval for a card? And by that time, usually, I mean, post-op pain for like a dental procedure, this is the only one I picked in a time, is it may be only 7 days. And so a responsible physician should only make it a short, so they don't go down that track of opioid dependency. So in that scenario, I can't see how a dentist or a provider like that advocate for a person to get a card if by the time they get the card, theoretically the pain would be gone. So that was a little confusing to me as I read it, and I read it a few times to see what scenario would that fit in, unless the patient already has a card, but I guess he doesn't need to use it then. So,
well, and it could be in anticipation of a procedure. So if you have one that is proactive, I think that is a scenario that could be presented with, I know I have this procedure coming up, we want to do this, rather than a prescription for opioids. So when you do have oral surgeries that aren't emergent.
Okay.
So
that's a scenario. I'm not saying that that's the run of the mill, nor am I saying it was discussed by the legislature. I'm just letting you know that I do think that there is an example where a person could plan and have their card in hand.
Yeah, so that's a potential gap then, because
yeah,
and so because at least as the place I work, we have a lot of folks that end up in the emergency room and then they get emergency procedure, and so it kind of limits their theoretical choice of what substance they use for pain control. And so because we harp on opioid usage or overusage. And so marijuana, I think maybe for some folks there is a good alternative, but I just don't see the timelines working out for that scenario. I don't know if there's an answer to that. But
Anything else to add?
I would just add, I would agree with what Deborah said. If there was a situation where maybe a physician was proactive, they could register with us. The patient could register, but that would have to be under those circumstances.
right.
In that event, if they did, the online registration system does allow, a 1 to 3 day turnaround time. But again, you have to be registered. You have to have your user ID and password, and that does take some planning.
So as a follow-up to that, then me as a physician who did the procedure would limit their use of that card for only whatever time frame, like 30 days or 60 days, I guess.
60 is what
60, yeah. So then I would, as a physician who did a procedure for pain control for that patient, which is my responsibility, I would say after 60 days, your card expires.
correct.
And they'd have to go through another process for a new card.
And the physician has the ability to do that.
Yes,
Then
that
the
would be
physician has
that would be at the discretion of the physician. Exactly.
Thank you. Did you have any general feedback for us based on the public testimony that you heard today before we go to questions from board members about it?
The only thing I'd like to make note of is, each of the applicants, as they apply, there's different scenarios. So a lot of these applicants have case-by-case situations. Our average turnaround time for mail processing is currently 10 to 15 days. Sometimes if we do see an influx in mail, we might go to about 20 to 25 days. But typically it's about a 15-day turnaround time. Now, should maybe something be wrong on the application or there be an error, then it takes time for us to work with that customer, which could lead to longer times. But on average, it is a 10 to 15-day turnaround time for mail processing.
Other questions from board members? Commissioner?
I guess this is kind of procedural, but also, excuse me, also substantive. With the written testimony that we've received, there are some proposed changes. Have staff had time to look at those and make any recommendations to us? And then just from a procedural perspective, particularly since this is an emergency rulemaking, what's the process if we want to incorporate any of these?
Right. So the recommendations that you received in writing this morning were not provided to staff until the day of the hearing. The constituent, however, is aware that this is emergency. We're planning on coming back for a permanent rulemaking hearing in September. So it's a fairly short window of applicability so that they can take time to study and then work with the constituents on the recommendations. So from a board authority, and Jen, correct me if I'm wrong, if you see something in here where you have a major concern with the emergency rulemaking, the board at your discretion may certainly do what it will in terms of making revisions, but otherwise know that the traditional process will kick in and also apply to meet the constituents' needs.
So unless we make those changes, we would be utilizing the verbiage that's in the document that we have without the changes now. But then in September, there's a possibility to come back and correct that.
Correct. Yes.
Super. Great question, Commissioner. Yes, ma'am.
So I guess the next question to the staff would be, I know this is short because you just received this, but how do you feel about these recommendations that we have in writing?
I'm not sure they've had.
We haven't had a chance to review them. They were handed to us when
Right.
it came up.
I understand.
So we haven't had an opportunity to review them as yet.
I understand. Thanks.
Okay, other questions from board members? All right, seeing none, thank you all very much for being here.
Thank you very much.
We appreciate your time. All right, so I'm going to close the record and proceed to board discussion. So based on the information we have in the document and the public testimony and then the additional information presented by staff today, what would we like to talk about before we move to a motion?
So I just want to be clear that we can discuss these additions from, that we have in writing at the September meeting.
Absolutely.
Just wanted to.
And those will be submitted as formal, right, feedback?
Right. So I think what will happen is that the staff will study them and you will actually see updates in the packet to say, similar to other stakeholder feedback, here's where we did make a change, or here's where we didn't make a change. Board of Health, here's why we didn't make a change. And so that they'll do that analysis and embed it into the document, which is our standard process.
And then in the same vein, would we just ask the staff to please address some of the issues that were brought up by Martha Montemayor? Please.
Montemayor, yeah.
Thank you.
All right, no showing off. That's it. Okay, other deliberation or feedback?
Were any of the organizations that are represented by these comments, were they at the stakeholder meeting discussions?
So because it's emergency rulemaking, they haven't held meetings, but they were able to provide a draft. So as soon as the session ended and we knew that we had like a lock on what the language was, we started developing the packet. It got done toward the end of June. So we sent it out to our stakeholder list, which include individuals that are part of those organizations. No meetings have been held, and I don't know if they will based on the feedback received, as opposed to saying, hey, send us your suggestions if you see something and raise something. So it's a little bit less, because so much of it we lack any discretion to make a change. The only real area would be the length of the card for disabling medical conditions. Everything else, you pretty much need to align with statute. Yep.
Thank you.
Other questions, discussion? All right, seeing none, because it's an emergency session, I will make the motion. So I move to adopt, this is Matt Van Auken, I move to adopt the proposed emergency rulemaking for 5 CCR 1006-2 regarding the medical use of marijuana. The board finds that immediate adoption of the rule is imperatively necessary to comply with a state or federal law or federal regulation or for the preservation of public health, safety, or welfare, and compliance with the notice provisions of Section 24-4-103 of the State Administrative Procedure Act would be contrary to the public interest. Do I have a second?
Second.
Hearing a second from Commissioner Engels. All in favor, say aye.
Aye.
Aye. Any opposed, same sign. Okay, the motion passes. Thanks again to everybody for being here today. And all right, we'll close that item and move on to the next items. Yes? Miss anything? Great. Thank you all very much. Okie dokie. So now we're going to move on to the portion of the agenda that is a request for rulemaking hearing. So we're going to remind folks that there are no public comments received during the request for a rulemaking hearing. Please contact the individuals identified below on the agenda if you want to provide feedback about the proposal or proposed changes. I'll welcome up staff to speak to us about document 2 now. So Chris, you're pretending to be Randy Kirkendall today then. You'll just be here for a half a dozen things. Thank you, staff, for being here today. Please introduce yourself and then proceed.
Good morning, everyone. Again, my name is Chris Wells, and I oversee our Center for Health and Environmental Data here at the department. And I also oversee the Office of the State Registrar of Vital Statistics, which is often referred to as the Vital Records Program.
And good morning. My name is Gabriel Thorne. I'm the operations manager for Vital Records.
Thank you. We are here today to request a rulemaking hearing to consider proposed changes to the Vital Statistics Rule 5 CCR 1006-1, which stems from the Vital Statistics Act of 1984. The rule changes are due to the recent passage of House Bill 19-1039, or otherwise known as Jude's Law. The department has reviewed the rule pursuant of Section 24-4-103.3 CRS and has recommended changes to the rule concerning the following areas in order to align the requirements with what is now in statute. These are grouped into 4 areas: changes regarding intersex designation, regarding the sex designation. Birth certificates will only be able to be assigned as male or female at the time of birth and will no longer be given the option for that intersex designation. Secondly, there will be changes to the rule concerning amendments. Individuals who have followed the process to change the sex on their birth certificate will no longer have their birth certificate marked as amended, as previously required by statute, but will receive a new certificate that does not contain any reference to a previous version on record. Third, X as a sex designation option on the birth certificate. So once a birth certificate is registered as either male or female at the time of birth, any requests in the future to change the sex designation on the birth certificate come with the options of changing the sex designation to male, X, or female. In other words, X cannot be selected at the time of birth, but can be selected later and is intended to represent anyone whose sex does not fit into the male or female designations. And finally, changes to the requirements for minors changing sex on the birth certificate. Minors now require a physician's verification that they've undergone a surgical, hormonal, or other treatment as appropriate for the purpose of gender transition in order to change the sex on the birth certificate. And this is just in accordance with our rule. So next I'll hand it over to Gabe here to talk about our stakeholder process to date and any current feedback that we have received.
Okay, so for stakeholder feedback, the department has conducted stakeholder engagement, and we've identified 19 stakeholder organizations. We sent out the rulemaking packet to stakeholders on July 1st. As of July 17th, we've only received one response to our form, and that response was in concern with the practice of no longer marking changed birth certificates as amended. The department will continue to monitor feedback on these topics and incorporate additional feedback analysis into the packet if this matter is set for hearing.
So with that, that is our brief presentation for you all. We'll be happy to answer any questions that you may have. But overall, we are just aligning our rule with what was passed in Jude's Law.
Thank you very much for that additional information. I'll speak only for myself and nobody else. This feels a little contrary to the thing that we seem to be celebrating not too long ago here as a board. We understand your responsibilities as staff for the department is to align the rules and regulations with the bill that was passed. We all had an opportunity to review the bill. Begins on page 11 of the document that we received from you all. So thank you for providing that for us. That being said, I'll open the floor to additional comments or questions. I don't mean to keep looking over to my right, Commissioner Ingalls. No, all right. Mr. Turk.
Yes, I was giving everybody else an opportunity.
Thank you.
So this is less question for staff. I am fully aware that the changes being made, as our fine president indicated, have to align with the House bill that was passed. So it's more editorial. But I kind of echo Matt's sentiments that I am a little disappointed with the direction that this took. And I purposely did not engage in kind of reviewing this as I was going through to kind of keep an even floor so that I could discuss it here. I'm kind of wishing I hadn't done that so I could comment earlier. But just kind of some of my comments. I feel like the rule that we passed in December was fairly progressive. And so it's a little frustrating to see that this bill rolled back some of that progress that we put into the rule already. I appreciate removing the amended piece because I kind of brought that up in December, that is kind of an important factor for this community, not kind of putting a target on a document where people could start questioning and discriminating. So I appreciate that piece of it. I'm less concerned about removing intersex because X is more encompassing and kind of factors that in. So I'm less concerned about that. I'm more concerned about adding back in the requirement that minors have to somehow undergo some sort of treatment or surgery. And I'm pretty frustrated about that because I feel like I said, what we put into the rule allows minors that maybe don't have full support from their parents or family to be able to do some of this. And I feel like this kind of is going to hamper them in that, not to mention the whole financial piece and insurance and things of that nature that are barriers for doing this. So just want to get on record that I'm a little frustrated about this. And I know staff can't really do much about that, but I wanted to make sure, like I said, that it was on record. The only other piece I'll bring up is I'm kind of surprised about the birth certificate at birth and removing that piece because from a data standpoint, I feel like that's something the department would be interested in knowing at birth and to be able to kind of track that and see how, different issues that come up later in life might be affected by being born intersex. So I'm a little surprised that was rolled back as well. And so that's my last little bit of editorial comments on that. I appreciate staff working on this, and I'm sure you kind of expressed our concerns when this was going through. So thank you for that. And that's really all I wanted to comment. So
Thank you for your comments.
Yeah.
Sure.
Commissioner?
This is yet another procedural question. What would happen if we, as the Board of Health, incorporated those updates in contempt of the legislature, as it were?
I've got to run to the restroom.
So Elizabeth, we need to make a note that Ron and Pat never get to sit beside one another. So it is at your discretion in terms of how you would like to document that. Certainly when we're developing the minutes, that was your one vehicle for you all in terms of if you're wanting to make a formal communication to the department, you can certainly ask that I draft a letter to the department so that there's sort of a written communication to that effect, so that if there is more discussion, you have a very firm communication from the board about their position on these issues. You do have perhaps more creative solutions available to you. So full disclosure in terms of if you don't want to adopt the proposed change, but then you're asking the department to be out of compliance, it will get stricken. And then you will go through the same thing we had that hour-long discussion about with the General Assembly saying you're taking on a fight. And so I would not recommend that particular course of action, but I do think that we can, and for what it's worth, Mr. Turk is correct that the department at the House hearing did make sure that there was a record of the department's work as well as the Board of Health's work in this area. So I will tell you that it was communicated. It was just simply lost, perhaps, exactly how progressive some of the provisions were. So those are sort of your continuum of options. Does that help?
So it sounds like we need to go back to the legislature next year.
So I do think to be able to say if there is a forum, whether it's you in your individual capacity, or if it's for the board or for the department to say, hey, we want you to know that this is a consequence of your decision. Certainly the legislatures that ran the legislation were the same folks intimately involved in your December rulemaking. I could explore whether or not it would be considered a warm letter to just express the concern to those particular bill sponsors as a middle ground. So if you would like, I could speak with our legislative liaison to just say, we want to make sure you know that this is something that happened as a result of the legislation that was passed.
So what about folks that in this window of progression has the form been effectively changed? And if so, what about folks that are filling out the new form that is now being changed again? Like how does that all work just from a logistical perspective?
Go ahead.
Okay. This is not set to go into effect until January 1st. So currently, we're still under our current rules.
That were passed in December.
Correct. So
and what happens to all of those, birth certificates that might be marked away that is now being
amended? Right.
Point forward only.
Right.
Point forward only.
Yep. So if I'm a constituent and I want to go through the process, the amended annotation is as was communicated to the board in December. Vague and high level, but it still has an amended annotation. So pro con, you don't have to have a treatment or procedure if you're a minor, if you go forward for the next year. But then the request for the amended on the birth certificate, that is an improvement, as Mr. Turk indicated, that happens on January 1.
Right.
That's correct.
Thank you. Ms. Hammond?
I really like your recommendation, Ms. Nelson, about a letter to the legislators that helped us with the initial bill. Because as Commissioner Engel mentioned, I think the next step needs to be another battle at the legislature to accomplish what we had hoped we were accomplishing this time. And so I like the suggestion of your letter and would recommend that.
Surely there's got to be something from this side of the table. I do like the Jens on that side, though, so it sort of keeps us honest over there. Yes, it was. Anything?
It was biased when you were only.
I was making my way, I promise.
I am in full support of proceeding as with the letter.
Great. Great. Looks like we all,
Do we need a formal motion to move that forward or just by consensus?
nope.
You
just
done it,
consensus.
yep. And so if board members are comfortable, usually the procedure is that I'll start exploring that, working on a draft, and then I work with the board president to make sure that it's expressing your will, and that way it can be done in a timely fashion.
Great. All right, so back to the matter at hand. Is there any further discussion before we decide if we're going to put this forward for a rulemaking hearing?
Deb, how long can we delay putting it forward to a rulemaking hearing?
Sounds like it has to go into effect at January of 20.
It does. So we will have an incongruity where we are not providing a service. So you're basically creating confusion for all of those local offices and registrars with what do we do, because the department is in conflict. But in terms of if you're looking for that cycle of correction, you're looking at having them run a bill in January, making it signed and effective in January, running an emergency hearing in February. So then your window of backsliding is like 6 weeks. That's, if all the stars aligned. Okay.
I don't know, Sean's kind of magic.
All right, so do we have a consensus to set this forward on a calendar this year for rulemaking hearing? This side of the table, how's everybody? Yes, we good?
It sounds like our hands are tied.
It sounds like our hands are tied. That's exactly right. All right, so may I have a chair for? Oh, well, boy, I just can't win with Dr. Estacio. No, seriously, is there? I know everybody's waiting for Mr. Turk.
No, I didn't chair the last one. So.
Yep,
I can chill.
appreciated. Dr. Barrio has agreed. Thank you.
January, you said?
Before January.
So they'll come back in September.
Okay, so we'll see you back in September. Thank you both very much.
Thank you very much.
Nice socks. All right, let's move as quickly as we can on to document 3. I think I saw James here. Hi, James. Please come on up and talk to us about 6 ECR 1007-1 radiation control. Yeah, James has been known to set a record or two for a number of pages that we get. That's right.
I still love the
I do. The comments make all the difference for me. That's for sure.
Good.
All right. Good morning.
Good morning. Again, my name is James Jarvis, and I am the regulatory lead for the radiation program in the Hazardous Materials and Waste Management Division. With me here today is a couple of my colleagues. I'll let them introduce themselves.
So my name is Catherine Lieberman. I am the X-ray unit supervisor and mostly oversee the administrative and enforcement and compliance side of the X-ray unit.
Hi, I'm Jim Grice. I'm the Radiation Control Program Director here at CDPHE.
Thank you all for being here today.
All right, and thank you again for allowing us to come before you today. We're here to request a rulemaking hearing be set for 3 of our rules. Specifically, we're requesting changes to 6 CCR 1007-1 Part 6 of the regulations. And this is our rule that provides operational quality control, radiation safety, periodic certification evaluation, which is inspection, and radiation safety related requirements for X-ray machines used in the healing arts and specifically in diagnostic medicine. As you probably saw from the rule package, we're making these changes primarily for conformance to the 2015 changes to the model regulation put out by the Conference of Radiation Control Program Directors, which is a big word, CRCPD, which is actually something required by our statute. We're required generally to be consistent with those requirements unless the board determines that some other language is needed there. And as I think you mentioned, Part 6 is a very large rule, as well as Part 2, that again affects all types of medical facilities. So we have a very big population of folks here, from dental offices to hospitals to veterinary clinics, chiropractic, podiatry, pretty much anybody using a diagnostic X-ray machine. What I'd like to do is just summarize at least a few of the high points of some of the changes being proposed. Again, we're proposing changing a number of definitions in the rule, deleting, modifying, and again, those are for conformance to our Part F model rule, and in conformance to other parts of the rule sections. We're also proposing to add details for the quality control and radiation safety programs required by the current regulation. And one example is that specifying an individual oversee the quality assurance program at these facilities. Right now, we really don't have any designated person in the regulations for that. We're also proposing to add a requirement for use of mobile and portable X-ray machines, such that facilities establish a procedure to kind of evaluate their use. Again, these are machines that are either carried or typically driven around, very heavy machines, to various parts of a facility to take X-ray images of patients that can't necessarily move. One of the Part F changes here in that model rule that we're incorporating, and this was something that was in our rule some number of years ago, and then it was taken out, and again, it appears in the Part F that we're working with now, and that is to limit the use of mobile and portable X-ray equipment to those cases where it's either impractical to transfer a patient, or the patient's medical condition wouldn't allow them to be moved to a fixed facility. And that has to do with the quality control, or some cases the lesser quality control that can be implemented with those portable machines. Another item in Part 6, although this one is not required by the Part F rule, but came about in part as a result of discussions with stakeholders, was or is proposed to kind of clarify the requirements for mid-level non-physician providers who may be operating or overseeing the operation of certain X-ray machines. Right now in our regulations, we require that the operator typically be a physician themselves or a radiologic technologist, and that's kind of the limited scope area that they do. What we're proposing is to expand that a bit and allow these mid-level providers under certain conditions to use those X-ray machines or supervise the use, because we're already seeing it either through other statutory requirements or other sort of scope of practice activities. We're also proposing a requirement that facilities using computed tomography or CT, or that perform fluoroscopy guided interventional FGI procedures would be required to establish committees to oversee those activities, and in particular the radiation safety aspects of those devices. It's been shown, I think, over the last 20 years, and I think there's some data in our package on this, but the amount of use of both CT and FGI procedures has increased immensely over the last 20 years, and as a result, the average dose to patients has simultaneously increased. We're also proposing some specific changes related to dental use, which include a proposal to phase out the operation of older, higher dose dental intraoral imaging systems that operate below 51 kVp. And that's something that's generally recommended by national radiation protection organizations, and some other states have similar restrictions on the use of such machines, or at least operation at that lower level. Based on stakeholder suggestion, the draft proposes to phase in a requirement for rectangular collimators for intraoral dental imaging to help match the shape of the X-ray beam. And again, if you've been to the dentist lately, typically the X-ray machine has a round collimator. The beam coming out of that is round, but yet the receptor is rectangular. And so there's a lot of area around that receptor that is contributing to patient dose, but in fact doesn't create any benefit to the patient there. So rectangular.
Big square hole, is that what I'm hearing?
Exactly, yes. I was going to use that analogy, but
You're welcome.
thank you. And again, this has been a recommendation of national radiation protection organizations for a number of years, as well as I think other various dental organizations, and they just haven't seemingly have a need to implement that. And again, that was something that came about at least from a portion of our stakeholder committee, or I'm sorry, our stakeholder groups. We've provided some regulatory relief regarding the operation of handheld X-ray units. Studies have generally demonstrated that occupational dose for these systems is generally comparable to that of the fixed systems. And these are typically essentially look like a handheld cordless drill. They're about that size, battery operated, and they're used often in dentistry, sometimes in veterinary medicine. And what we've required up to this point is folks operating those have lead aprons, ring dosimeters, radiation dosimeters, as well as whole body dosimeters. And so we're reducing that a bit based on this kind of more recent information and data to basically limit it to what they would be required to do for a fixed facility, which is essentially a whole body dosimeter. And finally, the other Part 6 item I just wanted to mention was the reduction in the current requirement for patient thyroid shielding during dental imaging to only apply to pediatric patients, again, consistent with, at least say, some current recommendations in most national radiation protection organizations. They're suggesting that thyroid shielding be required for pediatric patients only, and it's generally a recommendation for adult patients. And right now, our current rule says you have to use it for everyone, regardless of age. Part 2 is another rule we're proposing some amendments to. This rule contains the registration requirements for pretty much all medical and non-medical X-ray facilities, service companies, qualified inspectors, certain operators of machines. Some of the more significant changes to Part 2 include a little bit of streamlining for the registration process for service companies. We've also added a qualification process for the registration of those mid-level, licensed mid-level providers to operate or supervise operation of fluoroscopy machines specifically. And again, this is a phased-in requirement coming about in 2022, giving both us, the program, and the stakeholders some time to kind of get to that point and be able to do that if they want to. We're also changing the inspection frequency to kind of make it consistent across the board for veterinary facilities to a standard 3-year period. And finally, the Part 12 change is just a minor wording change, but it does incorporate these mid-level providers into our review process for the registration of those mid-level providers. So they would be included in an existing fee structure that we have and kind of handled like we do other application review processes. So those are some of the highlights of our proposed rule changes. I did just want to mention our stakeholder process. The process for these rules actually began in 2017, followed by numerous general and focus group meetings in 2018 and 2019. As a result of these stakeholder processes, numerous changes were made to the rule, some minor, some more significant. In all, nearly 5,000 entities or stakeholders were notified of the opportunity to comment and participate in the stakeholder process throughout the last few years. Those stakeholders included all of our regulated facilities, all these X-ray machine facilities, users, individual registrants regulated under the rules, as well as numerous medical, typically medical-related organizations, societies, groups representing or otherwise affiliated with the regulated facilities. Throughout the stakeholder process, we did, again, receive numerous comments addressing specific technical requirements and issues. And as you may have seen from the rule, we did end up, I'll say, excluding a number of the more significant Part F changes. Again, these items were excluded due to implementation practicalities, need, cost, and technical considerations, primarily as voiced by stakeholders. Our Radiation Advisory Committee also weighed in on the proposed changes numerous times during the rule development process and rulemaking. And in the end, I think we received kind of a general consensus to move the rule to the next phase, which is where we're at now. So with that, I will conclude my summary. The radiation program would like to request that the board set a rulemaking hearing for September 18th, 2019 for these three rules. And I'd welcome any comments or questions from the board at this time. Thank you.
Dr. Stasio?
James, when you went through the stakeholder meeting, did a lot of organizations or facilities already adopt some of the changes since they're kind of based on guidelines and stuff, making the process not so hard because it's a lot of stuff.
There is a lot of stuff here. I mean, I don't know. I don't recall facilities necessarily indicating that. I mean, you know, one of the requirements I can say that was, you know, didn't make it in our final rule, but was part of the Part F model rule was a requirement that all CT facilities be accredited. And currently about 60% or so of our facilities are already accredited. So that, I don't know if that's an example of what you're looking for. Or,
exactly.
So, and I would say, yes, some of these facilities already perhaps implement some of these requirements. A lot of them are already driven by FDA requirements. They're just kind of translated into our regulations. In particular, you know, some of them are really fixed, and the facilities are just supposed to check on those, like source to skin distances, for example. Those are, you know, regulated pretty heavily at the beginning of the manufacturing process of X-ray machines, and then checked on during the inspection process by the qualified inspector.
So some of these requirements they like overlap with like JACO when we have site visits. So I imagine they would. And so you're nodding, you said yes. So.
Yes, they do. I think one of the newer requirements kind of related to that is pertaining to these committees. But I've also heard that JACO may be pulling back on that, but I haven't heard sort of the final word on that. So.
Okay.
And yes, I'll say JACO also does require under certain reimbursement processes, and I'm not an expert in that by any means, do require accreditation, for example, to get reimbursed under at least one of the two categories for CT imaging in particular. But a lot of the stakeholders, again, that maybe aren't affiliated with a larger facility wouldn't necessarily have the funding. Rural facilities may not have the funding to implement CT accreditation. So. And it's kind of, you know, more like the gold standard. That's kind of what stakeholders said that's something to achieve, but maybe shouldn't be regulated. But
okay.
Even though, again, the Part F model rule that we're, you know, kind of trying to adhere to does have that requirement in there. So.
Okay. Well, I appreciate all the hard work you did because this document's a culmination. It sounds like a couple of years' work.
It was a long time in the making. Yes. So, any other questions?
So 60% of facilities are accredited. 60% of the facilities are accredited. I am a believer in accreditation, so, we have higher standards for any type of practice. Is there a pattern of those who do seek accreditation? Is it mostly because of resources?
I don't want to speak for too many facilities because I think the situation is probably different for everyone. I think resources seem to be, again, based on some stakeholder feedback, in particular, I'll say from the Hospital Association, that would be kind of a limiting factor. There's also time involved in that. It's a couple-year process. I don't know if there's anything else. Yeah, and the cost of it, certainly it's, accreditation again and this is specific to CT or computed tomography is, depending on, the organization that you get it from, there's 3 that you can get accredited from, runs on the order of $6,000 to $10,000, kind of from the get-go. And then there's several $1,000s every year to a few years to maintain that accreditation. So.
Would it be a fair guess, I guess, to say that then maybe the larger facilities with more resources are the ones that tend to be accredited versus the smaller?
I would say probably on average, certainly, yes. They're going to have, I'll say, the deeper pockets to do that. But there are some smaller organizations, I think, that have accreditation as well. Again, it's something, again, for CT that Medicare requires if you're going to get reimbursed. So partly that could be dependent on their community, and who they serve with that. If there's maybe a large, older population that would fit into that and be only on Medicare primarily, they may desire to be accredited for that reason. So.
Other questions? Mr. Butts?
Thank you. This is kind of an upstream question. You guys, does staff from CDPHE participate in the CRCPD model code process?
We do. In fact, a number of our committees, a number of our staff members, including myself, participate on various committees through CRCPD. So,
for us laymen's, do you want to help us with what CRCPFCG?
Again, CRCPD is the Conference of Radiation Control Program Directors. So it's the folks that are equivalent to Jim, all in the various states across the U.S. So there's 50 of them, or
yeah. Well, not 50.
Maybe. Okay.
I think there's 38 at this point, agreement states in the U.S. And so each one of the program directors is a member of the CRCPD. They have suggested state regulations for each specific portion of radiation control rules. And like James stated, a number of us are on those committees. I have been on those committees. James has. We have a number of staff members. This one in particular, Part F, we did not have a representative on that committee.
Actually, can I adjust it? We did actually in the past. She no longer works for us, but she did. One of our staff members from a couple years ago was a participant in this particular Part F rule making or development from 2015.
And I knew all that, but Elizabeth is new, so I just want to make sure that she had access to that information. Of course.
It's sort of a follow-up question, I guess. As you look at their model and our application of that model in our regulations, you've tried to strike a balance between safety and access and things like that.
Yeah, and that's precisely correct. In fact, we had that very conversation this morning. That's the goal, is to get to a place where we have maximum accessibility and we're harmonized with essentially the national state of practice as well as the SSRs recommended by the CRCPD.
Great question. Other questions or comments from my favorite side of the table? No? We'll put you over here next time, Dr. Wade.
I'm going to podium in the corner.
All right. So other questions or comments? Seeing or hearing none, any opposition to placing this on the future agenda for rulemaking hearing? Seeing no opposition, we will do just that. Thank you all very much for being here today. We appreciate your time.
Thank you very much.
And we need a chair. Thank you. I always forget that part. Dr. Estacio, it is. Thank you.
Tom, do you want to do it?
I could give it.
And it's up to you.
But if you're.
So that way, at least our president can talk to me every once in a while.
It seems like you know a little bit about this, so you might be a fantastic chair for this.
I'd give it a shot.
Great, terrific. Thank you very
And
much.
I'll make sure I.
All right, Andrea, I see that you're here. Are you ready to come on up and talk to us about the CCCPD Grant Program Committee appointments? Did I get that right? Did I get enough Cs? Yes. No, it wasn't as easy as it sounds.
May have added some extra.
I may have added a C or two. Yep. Like my report cards in high school. All right. So you ready?
I am.
Okay, go ahead.
So good morning, everyone. I'm Andrea Wagner, and I'm the program manager for the CCPD Grants Program, which is the Cancer, Cardiovascular, and Pulmonary Disease Grants Program. So I'm going to lighten it up a little bit. Like, I just get to come to you all today and ask for your appointment of 4 different members onto our review committee. So we follow some standard procedures, the same ones that our tobacco grants program follows, where if a member serves a partial term, they're eligible for reappointment if they're interested in being reappointed. And if they serve a full 3-year term, then we post the position as vacant and they are eligible if they've only served 1 term. But we do open it up so if there's other interested parties, they can apply. So today I'd like to request your appointment for 4 different positions. The first one is for a chronic pulmonary disease professional. Dr. Heather Hoke applied for this position back in November of 2017 and served a partial term on the committee. She was interested and eligible for reappointment, so we're requesting that you will reappoint her to our committee. She's a pediatric pulmonologist and an assistant professor at the University of Colorado and Children's Hospital, Colorado. The second position is for a member who represents the rural interest in all of the disease categories that we address. And Mrs. Della Cox-Vieira has served a partial term of 1 year on our committee and was interested and eligible to be reappointed as well. She is currently the public health director for Alamosa County, and she's been in that role for 5 years. The third position is for a primary care provider, and Dr. Jennifer Fang has served in that role. She did serve a full 3-year term, and so we posted the position and allowed other individuals to apply if they were interested. We left it open for 4 weeks. Dr. Fang was the one who applied, and we'd like to request that she be reappointed as well. She is a family medicine physician, and she currently practices at Clinic of Family Health in Adams County. The fourth position is for a public health professional. Dr. Chris Wyant served in that position for 2 full 3-year terms, so for 6 years on our committee, and he was not eligible for reappointment. And so we did post that vacancy announcement as well, and we received 5 applications, which was wonderful for that position, very competitive. The CCPD Review Committee is recommending of those applications that Mr. Tristan Sanders, who is a manager for community and behavioral health at the Denver Department of Public Health and Environment, be appointed to that position. And I'm happy to answer any questions. All 4 of the positions we're seeking appointment on would start in August of this year, so August 2019, and they would go for a full 3 years through July of 2022.
Terrific. I just want to mention quickly how much I appreciate the additional bits of information for folks.
Right.
In past years, sometimes it's like, hey, there's this guy, Larry. We're like, okay. And it's much, much better overall, but I really appreciated the extra information.
Glad to hear it. We'll continue to do that then.
Yes.
Larry the Cable Guy, that's right. Well done, Ron. Okay, so any questions for Andrea about the slate of appointments? Dr. Sasio?
Just a comical side comment. I remember presenting to CCPD and Dr. Fang saying to me, "Hey, you were my attending when I was a medical student."
And you want to keep Sean? Like, is that the plan?
We would like to keep
You're
Sean
going to keep Sean?
if he's willing to continue, yes.
Excellent.
we shake it up a bit, so we like to move him around just to keep him on his toes.
Okay, so any opposition to anybody on the slate of appointments? Seeing none, by consent, we will approve them. Thank you very much for
Thank you very much.
the document and the additional information.
Thank you. Have a great day.
Thanks, Andrea. Okay, I see my favorite word on the agenda today besides lunch, and that is break. So let's take a quick 10. Does that sound okay to everybody? It's 11:20, so we'll see you all back at about 11:30. All right, let's go. All right, I cannot, I can't wait another second for,
All right, bring it back, people.
all right, I've been waiting with bated breath for an hour and 30 minutes now for an update from our executive director. So let's come back and I will turn it over to Executive Director Ryan.
Thank you, Mr. Chair. Let me pull up one thing here. So I'll start my report with a couple of emerging issues. Some of you may know that the department's been working on a hepatitis A outbreak since last October. It's among the homeless population. It started in El Paso County. It's up to 90 cases. We have seen cases in Pueblo County, one in Douglas County, a couple in Fremont County, and just recently we've seen it in Denver County and have done the DNA fingerprinting and know that it's all connected. So we asked for an emergency supplemental of around $500,000 to hire some temporary staff, pay for vaccine, and we're working with county jails in those areas and homeless shelters. And the local public health agencies have been just amazing. El Paso County Public Health in particular has done a very good job at getting their folks vaccinated. So has Pueblo County Public Health, and Denver is just stepping into this. So the reason we're so concerned is San Diego County spent about $12 million fighting their Hep A outbreak a while ago. And we say that the epi curve is sort of simmering and it hasn't yet done this sort of exponentially. So that's what we're trying to avoid. Next month, I will give you an update on a PFAS response plan that we are working on. If you're not familiar with PFAS, PFAS, look it up. It's I know Tom knows what that is. It's I was going to say, don't even try to pronounce the long words. It's a group of chemicals that's being called the forever chemicals. It's in everything from Teflon, dental floss. It's a substance that has been used in a lot of ways because it just has amazing properties, invented in like the 40s and 50s. But what we're seeing and what we've discovered in the last few years is it's in firefighting foam and used to put out petroleum-based fires at airports. Firefighters use it in drills. We see it at oil and gas refineries have had fires. So, and then it can make its way into the drinking water. And some of you may have read about Fountain, and that was the chemical that contaminated their drinking water. So we're doing an action plan. You're probably going to start reading about it more in the paper. And I would love to talk to you about it more at my update next month. And then I'll just say we've been working really hard on our strategic planning. The department has done an amazing job, a lot of work in a really short period of time. With our strategic plan, we've been doing the budgeting for next year so that we could ask for the resources we need around our goals. The governor's given us 4 big goals. And I think maybe next month too, I'll provide a more in-depth update on those. But it's basically air quality around reducing greenhouse gas emissions and ozone. Saving people money on healthcare, which for us is translated to addressing obesity. And we're going to end up scaling up the diabetes prevention program, an evidence-based program by the NIH that provides group level support and counseling for 6 months and then once a year. So really behavior change program. Suicide prevention. The governor started a mental health task force to look at the whole behavioral health system, particularly the system of care. We sit on that, and we've also just done a very thorough epidemiological review on suicide, on the evidence, on what other states are doing, looking at the data, what local public health agencies are doing in Colorado, trying to decide what are the strategies we want to implement. And then, of course, immunizations. And the goal the governor's given us for next year is increasing the MMR rates, measles, mumps, rubella immunization rates among kindergartners, trying to get that up. 92% is herd immunity. Colorado as a state is around 87%. But the issue is we see great disparities by area. So Denver, Boulder, Colorado Springs coming in third in terms of rates and numbers of kids who do not have immunizations. That's part of the vaccine hesitant parents or anti-vaccination movement is kind of causing that. And then we've got some rural disparities just based on access. So our team's putting a plan together. We've asked for some money for next year to roll out both a public information campaign that vaccines are safe and effective, and to give local public health agencies funding so they can go out and vaccinate wherever, through mobile programs or schools or wherever that makes the most sense. And then finally, I talk about strategic planning. We decided to dust off our vision and mission and refine that, freshen it up. And so we had staff help us provide some ideas. And then we got a small group together, gave us a couple of choices, and then senior staff did a little wordsmithing. Here's where we landed on. I'm actually really excited about these. Vision statement for CDPHE is a healthy and sustainable Colorado where current and future generations thrive. And then the mission is advancing Colorado's health and protecting the places we live, learn, work, and play. And that's the end of my report, but happy to take a few questions if we have time.
Like it too. It's very simple.
Yeah, I like them both.
Good. Good. Fully all-encompassing.
Yeah.
Mhm.
Everything we do, trying to do.
But easy to understand. Yep. Questions for
Kind of a
the
comment, maybe
Director
maybe
Hunsicker
a
Ryan?
question inherent in it. And with the immunization rate goals, in a population like Denver, you've got a bazillion people and it's easier to reach those goals. In rural counties like ours, where the population is a lot smaller, is there any thought of adjusting that goal for those places? I know like with our human services, sometimes we have so few cases that meeting the goals, we're one person short, and that puts us down below meeting the goal.
Are you talking about so that when you look at rates by county, their rates are?
Yeah, that either, the school and the public health is doing a good job, and, we've got a couple of extra kids, or conversely, that we've missed 2 or 10 kids out of the entire population, and that puts us below our rate.
So I think what you're describing is the issue we have in general with rural communities and rates, which I prefer to use numbers, even if you're talking about a trend, because most communities don't grow that quickly, rural areas. So for example, if you had 1 case of a rare disease in Gilpin County, and the next year you had 2 cases of that rare disease, you've now doubled the rate, right? And so if you compare that rate across the state, it's going to blink red, even though it's a very low number. So rates can be deceiving. The thinking about we're starting with Denver, Boulder, Archuleta, and La Plata counties. And the thinking around that was, and this is what we're doing with really all of our goals. As we're trying to ramp up funding and scale up, we're saying we need to look at the burden of disease and start in those areas first, which is why we're focusing Boulder, Denver, and then the other 2 counties. Boulder, Denver, highest number of kids that are not vaccinated, kindergartners that aren't vaccinated, but also highest rates. But Archuleta and La Plata also have high rates, given that they're rural. So we're starting in those 4 communities, and then we want to try and scale it. And what that'll probably look like is giving incentives to local public health departments that want to participate, that tend to have rates below the herd immunity. And also just simply thinking from an outbreak perspective, the more populated the area, the more likelihood that's where an outbreak is going to start in this state, and where we're going to see it spread first. So it's the focus on Denver, Boulder. Did that help? Okay.
Other questions? Thank you very much.
Sure, thank you.
That was very helpful. All right. Ms. Weaver, do you have anything to report to the board today?
A quick update on our John Doe's case, the medical marijuana doctors who are challenging their referral to the medical board. Reminder, the case is in the Colorado Supreme Court and is fully briefed. And we just heard from the Supreme Court that they have set oral argument for September 17th at 9 a.m. So we'll be preparing for that. I think you can also call in and listen if anyone's interested. I can get that information. So that should be coming to a close.
Good.
6 months or so.
Good. Thank you. Anything else? Fantastic. Thank you very much. Board members that are on committees, do you have anything to report to the board at large?
So last month we went over some.
Go red just in case, please, or green, please.
Last month we went over some programs and kind of reviewed some of the budget for the upcoming year and where we might, I think we might have some extra monies. And then
Tobacco, just so everybody.
Tobacco Review Committee went over Natalia presented the youth media campaign and funding, and then also there was a presentation of the This Is Quitting Project, a truth initiative, which was very interesting in terms of what we did. And then for July, we don't have a meeting. So.
Thank you, Dr. Sessia. Mr. Turk, did you have a report?
Yep. So we had our meeting of the PD Review Committee last week. And we're kind of in between strategic planning and kind of the heavy lifting right now. And so we're getting a lot of grantee presentations, which has been really interesting. We're moving into, I think, our second year now of our 3-year fund cycle. So folks have kind of gotten past the initial ramp up and let's get used to the project and the funding and are starting to really dive in. So it's interesting to see some of those updates. I think we're skipping we have a meeting next month to kind of incorporate our new members that you just approved. So thank you for that. And then we're going to kind of go on off for a bit here until we kind of have to ramp up again. So a bit of a slow time right now, but that's all right.
We'll enjoy it.
Yeah.
While you can.
Yeah.
Thank you. And then Dr. Bestula is on the GERC, which he obviously doesn't have a report. I just like to say GERC. And that's it, right? Those are the only committees. Terrific. Deb, do you have any administrative updates for us?
I really only have 2. I just want to let you know that the uniform credentialing application, which is processed through a volunteer group that is recognized in state statute, so we have no department program, did hold their annual meeting. They are not recommending changes to the credentialing application rule. However, they do recognize that the statute is quickly becoming obsolete and a little bit challenging to operate, given that it's a paper form that's mandated by statute and so much is automated, and the universe of credentialing and how much of that resides within the DORA universe of licensed professionals. So I think that they're having sort of a next steps check-in that they're trying to accomplish over the next 6 months, but given that it's a group of volunteers, we'll just sort of take it as it comes. And then I wanted to let board members know in terms of long-term planning that we are flipping what my mind had as your December agenda and your August agenda in part. So August, some of the time will be devoted to you all doing a work session, reviewing bylaws, procedural rules, review of open meetings, all of those great things that we try to do once a year as a check-in, as well as having a traditional meeting. So we'll do it here. We should still keep to time and all of that great stuff. And then in December, which we originally planned on doing in August, but now will be in December, we will be at President Van Auken CCB for a community learning event so that we can learn more about what it means to serve individuals with intellectual and developmental disabilities. And that will include presentations from our 3 executive directors from our organization, as well as CDHS and Healthcare Policy and Financing. Part of the schedule change was actually to give the Lieutenant Governor an opportunity if she wanted to attend. So we're hoping that that hold on the calendar will actually stay as a hold hold and that we'll be able to have a great event that should be really fun for folks, similar to sort of June where it was an interactive time. So that's all I really have for updates unless folks have questions for me.
Where will that meeting be held?
So it's here in the Denver metro area, and so pretty much interchangeable in terms of time for travel and all of that with this entity.
Thank you very much, Deb. I appreciate those updates, everyone. All right. I don't believe there are any other updates right now, so let's move on to our two presentations that we have today. Document 5 is a presentation regarding Child Fatality Prevention System State Review Team updates. So staff that is here that is going to provide the presentation to us, please come forward. And hi, good afternoon, morning. Good morning, afternoon. Yep, we're on the bubble. Please introduce yourselves to the board and then proceed.
So I guess I'll introduce myself. Well, Kate's passing around some documentation, but my name is Andy Wooster. I'm a epidemiologist and data visualization manager within the Violence and Injury Prevention Mental Health Promotion branch.
Good morning. I'm Kate Jankowski. I manage the Child Fatality Prevention System in the Violence and Injury Prevention Mental Health Promotion branch here at CDPHE. And I just want to start by saying thank you so much for having us. We last spoke to you about 2 years ago, but I know that some faces have changed, although I recognize some familiar faces. So thank you again for having us, and we're excited to share our work with you. So today, we're going to share with you a little bit about the Child Fatality Prevention System, which is Colorado's public health child death review process housed here at CDPHE. The system was formally formed in 2013 under the Child Fatality Prevention Act, although deaths had been reviewed in Colorado since 1989. The Child Fatality Prevention System reviews cases of children who die ages 0 through 17 in Colorado, and that's roughly 600 deaths among those age groups, or that age group in Colorado, but the Child Fatality Prevention System does a more thorough review of a subset of those deaths, some 200 deaths each year. And those deaths are largely due to injury and violence. Our leading causes of death are suicide, motor vehicle crashes, sudden unexpected infant death, or what you may have heard called SIDS, or sleep-related infant deaths, child maltreatment, inclusive of abuse and neglect, and firearm deaths. So these roughly 200 cases each year are reviewed by 43 local teams representing all 64 counties across our state, so some have regionalized, and they're largely led by our local public health partners. Members represent a wide variety of agencies and disciplines, from sort of lay community members, law enforcement, human services, schools, medical professionals, behavioral health professionals, and others. As part of this case review, they enter information into a national database, and then the data are analyzed here at CDPHE. Once the data are analyzed, we go through a process every year of prioritizing prevention recommendations to submit to the Colorado General Assembly as part of our annual legislative report. And today I've shared with you the executive summary of that report, which we just submitted on July 1st, 2019. So I wanted to share with you just a high level of our prevention recommendations that were prioritized for this legislative report, and they are in that document. So the first recommendation, and I should say, please feel free to stop me if you have questions. I'm happy at any time to answer them. Our first recommendation is around behavioral health promotion, and specifically, we're recommending better access to telehealth services, especially for our rural communities for behavioral health care. Increasing the workforce diversity of our behavioral health clinicians to better match the needs and populations represented in Colorado, and then integrating behavioral health into primary care settings. Our next recommendation is quality, affordable, and stable housing, followed by quality and affordable childcare, and then evidence-based home visitation, improving access to that for all families with young infants. Enhanced graduated driver license law in Colorado, enacting a primary seatbelt law, followed by enacting a paid family leave law, and then fund research on firearms deaths recommendation, and lastly, delaying school start times to start after 8:30 in the morning. So if you have questions about that, I'm definitely happy to answer in more specific detail. But a lot of the detail, rationale, and data we use to come to those recommendations are outlined in this larger report. Do you have any questions for me? I can share more about the recommendations, or I can let my colleague take over and share with you a little bit more about the data.
Can I ask questions now or wait? Let's wait.
Thank you.
Andy?
Okay, so thank you, as Kate said, for having us here to share some information about the work that we're doing within the program. I'm here sort of representing, you may have heard my title doesn't currently involve the child fatality prevention system, but I'm here today to represent some of our data reporting and data quality processes that are ongoing. And so I want to start by giving you an update on some of the changes that we've made to the system and some of the ongoing work that we have happening within the system. And then I'll provide you with sort of a snapshot of what the data from our most recent report looks like without going into a ton of detail, because I know our time is short. So over the course of the last couple of years, Kate and I really started working in this program at about the same time back in late 2015. And though our roles have sort of changed, we're still involved and obviously feel very passionately about the work. We have had some new staff changes that have really had a chance to reinvigorate the program and add some new ideas and some new expertise to the program. And so I wanted to highlight a couple of things that have come out of that staff turnover. First of those is we did hire a new epidemiologist for the child fatality prevention system, Sasha Mintz, who is here in the audience. And she has been a really great addition to the program, bringing in a lot of expertise. She came to us from the Colorado Violent Death Reporting System, so she brought a lot of that expertise. But she's also really worked hard to bolster the content of our work as it relates to equity and the different sort of systemic drivers of our outcomes that we see within the program. So really trying hard to understand why we're seeing some of the things and what systems contribute to those changes or those outcomes that we see within the program. We also had Megan Staten come on board as our new child fatality prevention system coordinator. She came to us with great training and technical assistance skills. And so she has really tried to bolster the support that we provide to local teams around both training for doing this work and the technical assistance when they're actually involved in that process. And so she's refined a lot of our materials and has really worked hard to make sure that those relationships with the local teams are good. We've also undertaken some work over the course of the last year or so to really start to make connections to existing state programs that could help to bolster the data that we do currently have. So a couple of efforts that we have wrapped up or that are ongoing or that we're getting underway relate to our sudden unexpected infant death grant that we have with the CDC. And so this last year, we connected with the Colorado Immunization Information System and linked our data with that program to understand more about infant vaccination rates and what that looked like for our cohort of infants who are dying due to sudden unexpected infant death. So we have a good deal of information about that. I'm not going to share that information with you here today, but if you do want to reach out to us, we can provide you with some of the findings from that linking. And then we're currently in conversations with the newborn screening program out at the lab. And so we're hoping to be able to link that to get more information about any underlying metabolic conditions that may have been affecting our sudden unexpected infant death population, just to really sort of round out the data set that we have and make sure that we're covering all of the bases for things that we know can contribute to sudden unexpected infant death. And I expect that going forward, we'll try to make as many of those connections to bolster our data as we can. And then a little over a year ago, and since the last time that we were here to present to the board, like so many of our other programs across the department, we have adopted Tableau as a reporting forum for our data. So when I was in the role of the CFPS epidemiologist last year, I worked to learn Tableau and then to create a dashboard that would report out on all of our leading causes, plus give our specific circumstance data to that dashboard. I think we have 1,600 plus views in the just over a year that it's been out there and available. It's really sort of reformed our reporting structure because we are mandated in statute to report out to local communities annually. And now we have a tool that can provide that data at the county level to each of those teams who are doing these reviews, and they can go in and filter and slice through the data in any way they want to get access to that data for their prevention recommendations. So we feel like that's been a big step forward for us in the program in terms of our data reporting and sort of modernizing that structure. You can see that at cochildfatalityprevention.com or on our CDPHE CFPS page. So those are the sort of technical process updates that I had. Kate talked a little bit about the data that we had, but if you look through the executive summary that each of you should have, you can see some of the data about what we're reporting on over this last 5-year aggregate of data. Each year when we produce the legislative report, each edition of this legislative report reports out on the last 5 years of available data. And for this most recent report, we're reporting on data from 2013 through 2017. We are a retrospective system, and one of the things that Megan, who I mentioned previously, our new coordinator, is doing is trying to make sure that all of the things that CDPHE can control in that process flow from the event to the time that it's reviewed and analyzed is really at the shortest time frame that we can get it down to. So really any of the delays that we're seeing are delays in the ability of the teams to get records and actually conduct the reviews. So we're trying to make it our part of the process as real time as we possibly can, given the limitations of the processes that go into it. But over that last five-year period, we reviewed deaths due to unintentional injury and violence, including accidents, homicides, suicide, and deaths of undetermined manner. 3,020 infants, children, and youth under age 18 died in Colorado over that 5-year period. As Kate said, we review roughly a third of those over this last 5-year period. The Child Fatality Prevention System conducted comprehensive reviews of 1,093 deaths over that 5-year period. I would guess 80% of that probably was conducted by our local review teams throughout that period. Let's see, while these numbers have fluctuated a little bit from year to year, they've remained largely stable. So we're really seeing about 600 deaths per year, with 200 of those being reviewed by the system. Our leading causes, as Kate mentioned, were youth suicide. We saw 261 youth suicide deaths over that 5-year period. Motor vehicle deaths, we saw 237. That includes pedestrian fatalities, ATV accidents, as well as passenger vehicle deaths. So there are a whole host of different kinds of events within that category. Our sudden unexpected infant deaths, we saw 228, 223 child maltreatment deaths, 168 firearm deaths, 61 unintentional drowning, and 33 poisoning deaths. And one of the things that's sort of unique to our system is that we don't necessarily, our cause of death categories are not mutually exclusive. So any particular event could be captured in more than one of those categories. As an example of what I mean by that, we could, for example, see a youth suicide death that was counted as a youth suicide death, also as a firearms death, and as a child maltreatment death, depending on the circumstances of the death and what the team's discretion was regarding whether or not child maltreatment or neglect contributed to that particular circumstance. I think a couple of the trends that just to highlight a couple of the trends that we've really been trying to monitor closely. Youth suicide deaths, we know that all suicide deaths in Colorado have been increasing, and we know that nationally rates of suicide are increasing. We have seen the same thing for our system among those 10 through 17 years of age in Colorado. In 2013, that number per 100,000 was 6.9. In 2017, that number was 12.1, so it was almost a 75% increase. I think encouragingly, our numbers for 2018, that cohort is now closed. We expect to see 60 events rather than the 72 that we saw in 2017. So we're seeing a slight decrease in 2018, and we'll hope that trend continues. But certainly something that is on the radar of our friends in the Office of Suicide Prevention and throughout the world of understanding youth health and well-being. Child maltreatment deaths identified by CFPS also increased over the period from 2.3 in 2013 to 4.3 in 2017. And there are a lot of possible explanations for this, including that our friends over our peers over at the Department of Human Services have also seen an increase over the same over 2016 and 2017, and also that the definitions for child maltreatment across those two programs differ pretty substantially, and we have quite a bit more latitude in making those determinations within our program than DHS does, but we are routinely in contact with them to discuss these numbers. So. And then in 2017, we also saw a slight increase in the total number of passenger vehicle deaths among our population, but that the rate did not reach statistical significance. And I will say that that increase was not outside the normal range of year-to-year fluctuations for the system. But that's a sort of a snapshot of some of the highlights from the system that we observed over the course of that last 5-year aggregate of data. We have a ton more information, including circumstance information. The program, what really makes this program unique is the additional detail that we get on each one of these events and the comprehensive review that goes into that process by these multidisciplinary professionals. So we have a ton more information. We'd be happy to share that information with you. So
thank you very much for that information. On page 4, your CFPS recommendations to prevent child fatalities. Most of these I'm clicking with your numbers. I'm clicking with the leading causes of death. The one that's throwing me a bit for a loop, and I'm making some assumptions in my head, and that's never good for anybody, is the delayed school start after 8:30. Can you connect that recommendation for us a little bit more?
Absolutely. Thank you for bringing that up. So this is a new recommendation for us in our system this year. We have had recommendations repeat over the last several years, but this is new. And this is in the acknowledgement that youth may not be receiving or may not be able to sleep as much as they should be, and that sleep is integrally linked to mental health and behavioral health more broadly. And there's some emerging evidence that by delaying school start time, you can allow youth to sleep longer, which will improve their mental behavioral health outcomes, and then may even prevent youth suicide ultimately. And again, this is emerging. We have several large school districts in the Denver metro area who've implemented this. Littleton School Districts and Cherry Creek both have an 8:20 start time for their high schoolers. And then Jefferson County and Boulder County are considering doing the same.
That's what you mean by youth is.
Yes, yeah.
Excellent. Thank you very much for that additional information. Yes, ma'am.
Mr. President. Thank you for the report. A couple of questions for you. Has it gone to the legislature yet?
Yeah, so it was emailed out to them on July 1st.
Okay. I was going to say the 2018 data is like just around the corner if we were able to wait a month or so.
For us, because the deaths have to go to a comprehensive review at the local level, that we're even on a little bit of a delay. So our 2018 cases won't be finished being reviewed until the end of this calendar year.
Okay, thank you. That's a good distinction. Who are the member agencies on the CFPS?
So we have a state review team, and then we have our local teams, and the disciplines are pretty similar across both the local teams and the state review team. But the mandated members are human services, public health, county attorneys at the local level, and schools. But there are, like I said, we have many people who are interested in this work, and so teams have the ability to invite any member that they think is relevant, and many teams often do have sort of ad hoc members who may come with expertise in a certain fatality or health outcome or just a vested interest in that death, and they have that ability.
So on page 5 of our document, it would encompass a lot that's in the circle.
Yes, exactly. Coroners.
Figure 1. Is it every entity that's in the circle, or
That's the hope. So there are those mandated
That's your
members.
perfect circle.
That's the perfect circle. Because we believe that every discipline or every person in that circle has a different type of information about this family or the death or the circumstances. And I think it's important to highlight that these cases were once reviewed at the state level, but we in Colorado aligned with what we consider national best practice in doing these cases, in reviewing these cases at the local level, because we acknowledge that that's where the information is about these families. And that's who actually can do something more actionable to prevent these deaths in their community.
And so, in other words, the recommendations are from a large group of state and local folks.
So with every case review, I didn't mean to cut you off. I apologize.
Yeah, oh, no, that's fine.
As part of every case review in our national data tool, there is a field that asks about prevention recommendations that could prevent future similar deaths. And each team ideally fills this out for each death. It doesn't happen every single time, but we do have a big body of these prevention recommendations. And pairing that with our data set, our most recent 5-year aggregate, we have several meetings throughout the early spring where we come together as a system, both local, state, and then sort of what we consider our content experts or our friends of our system to talk about which recommendations stand out to us based on our data.
Are there other new recommendations on the list?
Yes. So new kind of the behavioral health promotion recommendation is one we've made for several years, but this looks a little bit different this year. The new components around improving access to telehealth and then increasing the workforce diversity of behavioral health care providers is new. Integrating behavioral health into primary care is not a new component. Childcare is not new. Quality, affordable, stable housing is a new recommendation this year. Evidence-based home visitation is not new. Enhanced graduated driver's license law is not new. In fact, child fatality prevention system data was used, I'm not going to remember the exact date, but was used to help justify passage of that originally in Colorado. 2005, Andy says. I'll believe him. And then primary seatbelt law is not new. This is a recommendation our system has been making at least for the last decade. Paid leave is not new. Funding research on firearms deaths is new. Last year, we made a recommendation on firearms deaths to support those who work in home with families, whether home visiting nurses or child welfare workers, get some support on talking to families about safe storage of firearms, taking out any sort of political conversation, but just acknowledging it's the same conversation you would have about putting a fence around a pool or putting a baby gate at the top of the stairs or locking up bleach underneath the sink. So really from a safety perspective. But we also wanted to make another recommendation this year because we saw so many firearms deaths and because it's such an important topic to our system. And then the delayed school start times is new.
Very good. Thank you. That was really helpful. Other questions or comments? Dr. Barrio?
Quick question about drowning. You mentioned pools. Is that really the primary site where drownings occur? Because then it can be prevented by rivers and lakes and...
So not in Colorado. In many other states, pools are the biggest concern. In Colorado, it's open water and usually fast moving cold water.
What can we do to prevent that? More awareness?
I don't know.
More awareness potentially Colorado, because I think most parents, because nationally there's this campaign about pools that some of us make the assumption that that's the case, but it sounds like not in Colorado.
So our colleagues in Breckenridge, Colorado, they experienced several drownings in their community. And one of the ways they responded was to make sure that more folks are adequately trained in CPR and that folks that are bilingual are trained in CPR. So I think we can teach folks how to swim better and be more comfortable around cold water and acknowledging the dangers, especially of that cold runoff water. But it's hard to limit access because, of course, we want people to be out enjoying our beautiful environment.
Ms. Salmon?
Question, drug overdose doesn't show up.
Jamaica.
Drug overdose doesn't show up on here, and I assume many of those end up under suicide, but do you have usually have some statistics on drug overdose?
So we do have some statistics on drug overdose, and we tend to see, I think for this most recent 5-year period, we had 33 poisoning deaths, not all of which were related to drug overdose. So a portion of those would be, and I don't have the exact statistics here in front of me, But I know that only a handful, a really small proportion of our youth suicide deaths are due to drug overdose. We mostly see youth suicide either by firearm or ligature strangulation. So,
If you want to send the number to me, I can follow up with them later. It's not a problem.
okay.
I just, with the big concern right now about drug overdose, that maybe spelling that out in the future would be helpful, and especially knowing the age group that needs to be targeted.
For sure. And on our larger full report, we have several pages that cover our overdose data. But I think you make a really great point. And one other thing that I want to highlight about our system is that we've worked in partnership with the Office of Suicide Prevention and the Violent Death Reporting System to develop a suicide investigation form, which is just a tool that our death scene investigators can use in Colorado to make sure that they're collecting the best quality information. Because, of course, review systems like ours are no good without great information from our death scene investigators.
And poisoning can be many things. So, but is that where drug overdoses? Okay.
Or both, maybe, but
Yeah,
also young people
we
exposed to.
Sorry. So we do produce some statistics on drug overdose. I know that while it's a hot conversation both here locally and nationally, we don't tend to spend a ton of time thinking about that particular issue just because in relation to a lot of our other causes of death, it's a relatively small portion of our program. But certainly we do have statistics available, and we do each year when we do our analyses, we do break it out by drug overdose deaths, looking at both, looking at all intents. So whether it was unintentional or whether it was intentional, and sort of getting the sort of overall picture of what drug overdose looks like. We don't, I don't think much of that made it into the executive summary, but we do have a topic specific brief that would have some more detail about that. And then we have some more statistics about that on our dashboard as well. So I'd be happy to follow up if you have questions that you'd like us to provide more information on.
If you could, it's a major subject, and
Sure.
Amongst that age group that you have here, 15 to 17, I think is probably even more important. So
Yeah.
I'd appreciate that.
Yeah, of course. Absolutely.
Mr. Turk, and then Mr. Butts.
Just make your way around the table. I hope you didn't think you were getting out of here quick. So my question, so I'm focusing in on the 10 to 17 and the fact that half of the deaths are from suicide. Are you guys tracking the LGBTQ population and where that falls? Because we know that those attempts are statistically usually higher than the non-LGBTQ teens. And so I'm just curious kind of where that data is and where you're seeing. And I think the diversity workforce for mental health was probably addressing some of that. And if there was any other discussion about how we address those issues.
Yeah, so I don't know that my answer will be totally satisfactory, sadly, but not for a lack of desire. I think that's something that we really would like to have better data on. We recently were vocal opponents of the removal of some questions around sexual orientation and gender identity from the national tool that we use to capture this data. It was unclear to us why our national partners made that decision, but we sort of protested and got the questions added back into the tool, although we added our own and improved on them. We don't have a ton of data at the moment. What our approach largely has been to understanding this is really to describe the population that we do see within our data in the absence of that additional context, and then to provide what additional national context or additional context we can from our other statewide sources. So like the Healthy Kids Survey data would be used to bolster our data, just because we, like I said, we do have a lack of information for that particular context, but we recognize certainly the value and the importance of incorporating that context into all of those discussions.
Yeah, because my concern, you made the comment that I think this coming year or this past year that the number looked like it went down. My concern is that it it went up for that population, and it likely did. So I just want to make sure we're capturing that and aware of that and kind of using that to move forward on some of these recommendations. So
I think you bring up an excellent point. And as Andy said, we always encourage our partners when they're using death data to consider other sources, because what's so challenging from a perspective of asking, we don't get the benefit of asking the person most impacted when we're using death data. And so we know that there are significant inequities related to sexual orientation and gender identity. So that's definitely, if you have other ideas about better ways for us to address that in our data in the absence of actually knowing the gender identity or sexual orientation of a person who died.
Sure. And I've got a couple other data sources that I can probably send through Deb. It's going to be more related, obviously, to the transgender community, which has an even higher statistical than just the LGBT portion of it. But yeah, I can send that to Deb and have her send it out to you guys.
That would be wonderful. Thank you. We appreciate it.
Yep.
Thanks, Mr. Turk. Mr. Butts?
Thank you. So your recommendations, there's not funding specifically to implement those. I take these are broad recommendations to partners at the state and local level. How would you judge the uptake of those recommendations?
That is the $1 million question, and something I lose a little bit of sleep over. So we have seen, our current system has only functioned the way that it has in the last 5 years. And one of the big things that Andy and I have done, and now our other colleagues on the team in the last couple of years, is to make sure that this report is shared as widely as possible and that people have access to this information. And one way that we've seen, I think, an impact of our system, in addition to that graduated driver's licensing law that I told you about, is also with paid leave. And so if you track this type of legislation through the legislative sessions, you'll know that paid leave has been introduced since 2015, every legislative session. And including this session, we have failed as a state to pass a law to provide family leave to either new caregivers that's paid. But in this legislative session, the legislature they amended Senate Bill 19-188 and passed sort of an actuarial analysis. So the Colorado Department of Labor and Employment will conduct that actuarial analysis. It also directed the Department of Public Health and Environment to create a report outlining the health impacts of paid leave. And I think that our work is directly contributing to that as a system. We're saying that we know it's evidence-based to prevent child maltreatment, for example, but we know that lack of paid leave creates family stress, which is a risk factor for many of the outcomes that we work on in our system. But we have also partnered really effectively with groups like Colorado 9 to 5 and Good Business Colorado, and then the Colorado Children's Campaign, who for the first time this year took on paid leave as a legislative priority. So I think the progress may be slow, but I feel like we help build momentum and just help tell the story from our perspective.
Great question. Commissioner?
Another crosstab question, particularly in regard to the firearm category. It appears that those 168 are probably suicide, homicide, accidental death, but particularly in light of the HB 1077, the red flag bill, I think it would be very interesting to be able to have those broken out by those subcategories to help inform the conversation about why that bill is so necessary and be able to talk about some of the reasons why.
Sure. Yeah, I think that's a great point, and we do. I think in large part, since hearing really persuasive statistics from our partners in the Office of Suicide Prevention around this particular issue, we have always produced those statistics for our legislative briefs, the data briefs that go out. You can see those statistics by year and overall in our dashboard to see that 2/3 to 70% of all of the firearms deaths that we see in a given year within the child fatality prevention system are youth suicide deaths. And so we have some information there about the way that those firearms are stored, who they belong to, and it really helps to make that case that, when you think about firearms deaths, one of the things that you really have to be thinking about is deaths by suicide, and not what some people often think of, which is those sort of unintentional discharge kind of events, which really represent a tiny proportion of the overall number of those deaths. So we are aware of that, and we do produce statistics on that annually. Yeah.
Yeah, for your information, we on page 43 of the larger report, we shared that there were 64.3% of our firearms deaths, or 108 deaths, were due to suicide, and that 32.7% or 55 deaths were due to homicide. And then a much smaller proportion, as Andy talked about, 2.4% are those unintentional discharges.
Mr. Chuck?
Just to build off of the stats you just gave, are you tracking school shootings separately?
So separately, I don't think that the national data tool includes a way. Well, that's not true. There's a piece about mass shootings to say that this death was part of a mass shooting. Yes, I think is the short answer. And we could do more to share that out. I don't think we've ever shared any information about that. And I would guess it's largely, I don't know. What are your thoughts?
So I think we do have some of that. I think I have two thoughts about this. So the first is that we do have the ability to track that, and that was recently added into the National Center Case Reporting System. We have a mass casualty kind of event, which may help us to capture some of that information. If you're talking about a school shooting, where a single student dies as a result of the event, it may not capture those sorts of events, but I think we do have the ability, just in terms of staff capacity, to track and potentially connect those events so that we have a better sense of how our events connect to those broader events that make the news and are out there in the public sphere. We haven't undertaken that work so far, but I think it would be worthwhile for us to look into and just see if if there's anything really compelling that comes out of that conversation.
Right now, included in homicide, or just not included for firearms?
Maybe firearms, but also those homicide deaths, yes.
Yep.
It's partly what's so exciting about our increased capacity as a system. We have the partners, we have the expertise data-wise to do some data briefs on things like mass shootings. So thank you for that.
Great questions and comments, board. Thank you. Anything else? All right. Thank you both very much for your time today. We appreciate
Thank
it.
you. It was our pleasure. We really appreciate it. Bye.
Thanks for being here. Thanks. Did you want us to applaud? I felt like a light, maybe a golf clap or something. Oh, okay. Great job. All right. So next up is document 6, Colorado's immunization landscape, data to action. It's a fantastic title. Are you all ready? Come on up, please. Please introduce yourselves and then go ahead with your presentation. Go ahead and press so you get green.
About that.
Yes,
My name is Diana Herrero. I'm the Policy and Performance Administrator for the Disease Control and Environmental Epidemiology Division here at State Health.
Great.
Hi, everyone. I'm Heather Roth. I'm the Deputy Immunization Branch Chief, and I'm also the Program Manager of our Colorado Immunization Information System.
I don't know how you all fit your titles on business cards. It's like you need 3.
Very tiny lettering.
Really, really tiny.
Magnifying glasses.
Well, thanks for being here today.
So does this work? I'm just going to use that. Okay. So just a brief outline of where we're going today. I'm going to give an overview of some of the current immunization data sources we have for Colorado, kind of starting at a 30,000 foot level view and working our way down to state, county, zip code level, and then finally to school and childcare community level. Provide some key takeaways from those data sources, and then turn it over to Diana to talk really about how we use that data to inform our strategic priority. So I'm going to start with the National Immunization Survey.
Data has been collected through this method really since 1994, sponsored by the CDC. And that very first survey was actually, incidentally, in response to measles outbreaks in the early 1990s. Its purpose is really to provide household, population-based, national, state, and local area vaccination coverage estimates. It is a sample survey. I'll talk a little bit more about that. It's a random telephone interview. And then it combines that interview with the review of actual vaccination records provided by healthcare providers of the children included in the interview. NIS assesses 3 different age groups, 19 to 35-month-olds, the adolescent group of 13 through 17-year-olds, and then there's this influenza-only NIS that happens annually for 6-month-old to 17-year-olds. For the smaller, younger children, the 19 through 35-month-olds, the survey assesses all vaccines that are recommended by ACIP from birth through 18 months of age. For that adolescent cohort, the NIS assesses several vaccines: Tdap, meningococcal, HPV, MMR, Hep B, and varicella. And then obviously there's that flu-only assessment as well. One thing I want to point out about NIS is that it counts all doses reported, whether or not those doses are actually valid. So whether they were given per ACIP age and interval requirements. So in the latest published survey is from 2017. And that year there were a little over 15,000 children nationally included in the child NIS survey. And Colorado made up only 264 children of that number. Okay, so each state has a very small sample size. And then CDC says something about what this survey means for each area. The other thing I really want to point out too about NIS is that NIS rates reflect immunization practices that are 2 to 4 years in the past. So it's not incredibly timely. This is for the child survey. Even longer amount of time passes for the teen survey. So not a meaningful, it's definitely meaningful, but it's not timely. So I'm going to start by showing you our 2017 NIS vaccination rates for what we call the 7 vaccine series for childhood. So that's 4 DTaP, 3 polio, 1 MMR, 3 Hib, 3 Hep B, 1 varicella, and 4 pneumococcal vaccines. And you'll see that in 2017, our up-to-date rate in the state was 71%. So we're the red line, just slightly above the darker yellow, orangish line of the US, which was at 70.4%. You'll also notice that the Healthy People 2020 goal for this particular measure is 80%. So neither Colorado nor the US as a whole is meeting that goal. One thing I want to point out about this graph is that it also displays confidence intervals. Because these are coverage estimates based on small sample sizes, the confidence intervals show us the expected range that the true rate would fall into most of the time if this survey was replicated over and over again. So if this survey was replicated 100 times, 95% of the time, Colorado would fall within the gray box that you see. So in this example, the confidence interval for Colorado is 7.3. So that means our true rate for this measure is somewhere between 63.7% and 78.3%, 95% of the time, to be precise. Okay, the other thing I really want to point out about NIS is that it comes out every year, it's published, the media grabs a hold of it, and it immediately starts ranking states. Which has, some validity, of course, but this graph kind of shows you that it's not statistically valid. Okay, so this shows all states and areas included in the 2017 NIS, again, for that 7 vaccine series coverage rate. Colorado's kind of demarked by that red rectangle. And each of those areas has an upper and a lower bound for that confidence interval, okay? So if you just span your eyes across this graph, you'll see that with very few exceptions, both on the left and the right-hand side, those confidence intervals overlap. So you can't really say that Colorado is any different from any other state. I'm going to jump to one of our NIS teen measures, and that's the HPV vaccination up-to-date measure. So our sample size in 2017 for the NIS teen was 354 adolescents. Our HPV up-to-date rate for that year was 53.8%. So you'll again see us in the red, which is higher than the US average, which is 48.6%. One thing you won't see on this, but that I wanted to share, is that our initiation rate, so the rate of which patients get that first dose of HPV, is 72.1%. So that's pretty good. The confidence intervals are shown again here for your edification. The confidence interval for last year was, or for 2017, was 6.3%. Again, the true rate is somewhere between 47.5% and 60.1%, 95% of the time. And then you may have a question about why there are only 2 years shown here. And that has to do with a change in the HPV recommendation in 2016 that went effect in 2016. So that marked the first year of measuring HPV up-to-date status instead of a dose count. So you can be up to date with HPV with either a 2-dose series or a 3-dose series, depending on when you start. So a 2-dose HPV schedule is recommended for most persons starting the series before they turn 15. 3 doses of HPV are recommended for teens and young adults who start the series 15 or older, or who are immunocompromised. Then I included the same kind of graph that I did for the childhood series to again show you that with very few exceptions, Colorado's not statistically different from other states in terms of HPV coverage. So some key NIS data takeaways for the child survey in 2017. Our coverage for polio actually just surpassed the Healthy People 2020 goal of 90%. Our coverage for the birth dose of hepatitis B, the rotavirus, and that 7-dose vaccine series that I showed you were at or above the national average. But not shockingly, coverage rates for some vaccines are too low to protect communities from outbreaks. And specifically, I want to call out our MMR coverage, which would protect against measles at 87.2%. For the NIS teen data, our coverage for Tdap and meningococcal both met the Healthy People 2020 goal of 80%. But we significantly lag behind with HPV, even though all 3 of these are considered part of the adolescent vaccine platform. And while we continue to lag behind and fall short of Healthy People 2020, we are still above the national rate. So there's a silver lining. Ethnic differences? I think that may be part of NIS. I don't have that data with me right now, but I know they include race and ethnicity in their coverage estimates. So I'm going to dive a little deeper into data that comes out of our immunization information system. So SIS is a confidential, population-based, secured, computerized system that collects and consolidates both vaccination data and exemption data from people, from Coloradans of all ages. So we're a lifelong registry, womb to tomb, some people say. And the individual level data is provided to us directly by healthcare providers that participate in the system. SIS currently contains identified information for 91% of all Coloradans. So chances are you guys are in there. And then as of June, it included over 70 million immunizations. So the purpose of vaccine coverage assessments run out of SIS is really to provide population-based estimates at the state, county, and zip code level to measure both performance and protection. Talk a little bit about performance. So if you're going to do a performance-based assessment, you're going to be measuring the percentage of the population that's been vaccinated appropriately among those who are eligible for vaccination. If you're going to measure protection, you're really going to be measuring the percentage of the population that is immune from disease. So that would include both people who are vaccinated appropriately and who may have contracted the disease itself and have lifelong immunity. The data is, again, individual, and we can assess any age, any vaccine, any combination of vaccine series. And again, we can count all doses, just like NIS, or we can count only valid doses, depending on the purpose of our assessment. So this slide shows a county map generated using SIS data.
This is for that 7 vaccine series, the 431 through 314 for children 19 through 35 months of age. The state rate, if we were to combine all these, our state average is 72.29% for that series. Again, the darker shade of green, the green looks really awful. Looks better on our website. The darker shade you are, the higher the rate of the county is. And you can see the buckets, rate range buckets up there at the top. And this particular assessment was generated using what we internally call the standard rate. So that includes active patients with 2 or more non-flu immunizations on their record in CIS. And the reason I bring that up is because we do different methodologies working with our denominator. So CIS allows more timely and informative assessment and tracking of coverage over time. These 2 maps show the same 7 vaccine series coverage assessment at different points in time. So the one on the top left is for 19 to 35 month old. You see a lot of red and orange and yellow. And then as those kids age into the 3-year bucket, you see some of those counties moving into that green, less red, less orange, less green, or more green. So these assessments are including children in the specified age ranges with at least 2 separate non-flu vaccine visits in CIS as a measure of whether or not a patient is active and actually showing up at the clinic. So rather than just counting the services on their record, we're counting separate vaccine visits.
We go back one slide.
Yeah. This one?
Yes. So could you just maybe give us a little anecdotal data about why Larimer County, for example, is so darn good compared to others? Or looks like Cheyenne is even, like on mine, Larimer's like super, super dark green.
Mm-hmm.
So is there any anecdotal data you could give about them versus other counties?
Well, we do know that denominators are different in counties, right? So it's probably easier to immunize. I'm not going to use Larimer, I'm going to use Cheyenne. It's probably easier to immunize 75 adolescents as opposed to 7,500 in one of the metro areas. So we know that. The other thing that we've heard, I think, anecdotally, is that there are some potential access issues in rural areas, so that you can kind of see that on, the Eastern Plains as well as kind of up in the Northwest. But for Larimer specifically, I don't know. The other thing about Tdap is that you should know it's a school-required vaccine. So it's got some punch behind it that HPV doesn't, for example. Mm-hmm. All right, so I'm going to move on. Oh, we were talking about the childhood series, weren't we? Anyway, now I'm showing a Tdap map generated from CIS, using CIS data for 13 through 17-year-olds. The average state rate is a little over 74%. Again, the darker shade of green, the higher the county rate is for Tdap. And this was generated using that standard rate. One thing we've implemented recently is a weighted rate for adolescents because they don't present in the clinic as frequently as your 12 to 18-month-olds who come in, every few months for services. Adolescents are a different animal in a lot of ways. And so we've explored various methods to, one, control for denominator inflation. So we have a really great sense of patients who are coming into the state or who are born here and who receive services because those are reported to us, but we don't have a great handle on when patients move away. And so it has really led to some denominator inflation in our system that impacts the rates that we can run. So in this particular one, the assessment used a methodology in which adolescents are weighted according to the date of their last vaccine service. So the more recent a service, the closer that adolescent is weighted to 1. And so you'll see that these rates are pretty high compared to the last map I just showed you, over 90. This, I want to call out, is an updated slide. This was not in your original packet. So we were generating rates, and I noticed that our HPV rate from CIS was significantly different from our NIS rate for CIS. And when our data unit had investigated that, they realized that a small piece of code was erroneously omitted from our custom calculated rate that we included in our original slides. So we noticed that Monday. So I want to give you a little bit explanation behind that. So many adolescents who were in process for the 3-dose series and had their first dose before 15 years of age became eligible for that 2-dose series completion starting in October 2016. So that ACIP rule change is retroactive to any adolescent who had received that HPV vaccine before the age of 15. Some of those adolescents had received 2 doses that were too close together, not obeying that minimum interval spacing. So that meant they still needed 1 more dose to become up to date on that new 2-dose schedule. Our code didn't go back and look for that. That was fixed Monday. And the rates in this PowerPoint reflect that change. It's about a 12% gain, which is good. I'm glad it went that way and not the other way. So this is using that same weighted methodology for those teens. But again, I wanted to include this to point out the stark difference between Tdap, which was really green, and HPV, which is not green, even though those vaccines should be given at the same time together. Here's another kind of stark difference between those 2 adolescent vaccines where you have Tdap on the top. This is a trend since 2015. And then HPV on the bottom, where you see some gains in HPV, but it's not to the point where we are with Tdap. So some key data takeaways from CIS. Coverage rates are calculated based on the data reported to CIS. We don't have a reporting mandate, so we know that we have providers who are immunizing across the state who are not actually sending that data to us. So we do have some data completeness issues. As such, the CIS-generated rates are likely lower than the true rates for counties. Our statewide coverage for that childhood series falls short of the Healthy People 2020 goal. The 2 counties do surpass that goal, Cheyenne and Prowers. Our statewide coverage for Tdap for that adolescent age group falls short of Healthy People 2020, but 16 counties surpass that goal. And then our statewide coverage for HPV, which is 52%, not the 40.6% that was in your original slides, lags behind the other adolescent vaccines and falls quite short of that Healthy People 2020 goal. I'm going to talk a little bit about now diving even deeper into school and childcare facility level data. So the state of Colorado, our department, through Board of Health rule, collects immunization exemption, aggregate immunization exemption data from schools and childcare centers every year, and calculates rates and then publicizes those rates on a website that parents and partners can access. I'm going to show you that today. Just a reminder, as far as who's required to report, public, private, and parochial schools with K through 12, as well as childcare centers, preschools, and Head Starts licensed by the Department of Human Services to provide care for 10 or more children. So these facilities can report their numbers either through an online data collection tool that we've created here, or through electronic data exchange directly from their school information system to ours. So electronic data exchange in this last reporting period actually accounted for 46% of our K through 12 students and 18% of our preschool students. We had 8 districts send de-identified FERPA compliant student level data from their systems. That included 700 K through 12 schools and 311 preschools. And the districts were Denver, Jeffco, Academy 20, St. Vrain Valley, Aurora Public Schools, Thompson, Cherry Creek, and Douglas. So we're able to use this data to generate state, county, school, district, and then actual facility level immunization and exemption rates. We assess childcare age children, kindergartners separately, and then K through 12 students. The kindergartners actually helps us fulfill any annual reporting requirement to the CDC. So that's why they're called out separately. And then we're assessing all vaccines required for school entry by Colorado immunization law. And we're assessing all doses reported. So there's no validity on our part in terms of what dose had been actually valid or not. These are all self-reported from the facilities. Okay, so I'm going to navigate X. All right. Here. Thank you. Okay, so I'm going to just show you a quick demo of our website. We have two different visualizations. The first I'm going to show you is parents and guardian. This is something that we have been encouraging parents to access to help make them decisions about where to send their child for school. So when they navigate to this visualization, sometimes it can take a little to heat up. I wonder if I can resize this. Just zoom it out. Okay. So you land here. You can pick whatever school or childcare you want from here. And I had an example I wanted to show you guys. So this is a school in Boulder. And it pulls up their data, the data that they reported, or the rates that we calculated from the numbers they reported. You'll see the fully immunized bucket here, as well as a red line showing you what the Healthy People 2020 goal is of 95% for all of those different vaccines. They also have an exempted bucket, which captures all exemptions reported. You'll notice that 100% of those were for personal belief reasons. And then we also have a non-compliant. So these are kids with an incomplete record or no record on file with the school. Below, you can see their district for comparison. So you'll see that it actually, by and large, it's pretty similar in terms of fully immunized and exemptions, but they're doing better in terms of compliance, like actually having paperwork on file for their student population. You can also compare schools to the entire state. And the bars are a little misleading here because you've got a 14% exemption rate at the school, but statewide, it's around 2, almost 3. You also see statewide, we're closer to meeting that Healthy People 2020 goal, and we surpass it for TDAP. Next thing you can do as a parent is compare facilities. So I am going, because MMR is so hot right now, I'm going to select MMR and show you it's really tiny up there. Okay. This is our feeder school. I'm going to show you that one. I'm going to compare it to another school that's not in our neighborhood, but again, for the sake of demonstration. You can compare as many schools as you'd like. This shows you their fully immunized rates side by side. So you can see Park Hill has 93% fully immunized for MMR, whereas this Gold Hill has 73%. If I wanted to change this metric, I could actually look at exemption status too. And you'll see that these are flip-flopped now. And Gold Hill has 30% exemption rate for MMR, whereas Park Hill has, 0.06% exemption rate for that particular vaccine. The last thing that we really updated and made, I think, a little bit more robust this year was our reporting map. So I am going to find Park Hill again. And this allows you to drill down your mile radius. So it defaults to a 5-mile radius. I can see all reporting public schools, all reporting childcare centers. If I hover around any of these, I get a quick snapshot of where they were in terms of being fully immunized for their student population for their last reporting period. And then I can take it all the way down to a 1-mile radius. Like if I'm really, making that decision about where to send my kid for childcare, this might be something I would use to compare rates between facilities. Moving to the partner visualization. When you land here, you get a nice summary of all reporting facilities in a minute. Okay, so you get school, kindergarten, and childcare all put together. So you could see the total number of school and childcares that reported was over 3,000 this past reporting period, which represents 81% of those that were required to report by rule, and almost shy of 1 million students. Pretty exceptional. And then you can see statewide how we're doing in terms of being fully immunized here, exempted, and non-compliant. You can hover over any of these ribbons on the top. I'm going to show you kindergarten. And you'll see that when I did that, our immunized really, really dropped below that red line compared to our overall state average. Our exemptions climbed too. If we look at childcare and preschool, you can see we're doing pretty well. We're really close to that red line. Still have some exemptions and some compliance issues. At the bottom for all of these, we have kind of a nice graphic to show you what percentage of total exemptions. Exemptions are broken down by what types, right? So we're not surprised to see that most exemptions that are claimed are for personal belief reasons. I'm going to show you some maps now. Maybe. All right, so this shows, we'll start here, the school district map for kindergarten MMR fully immunized rates. I know those are hard to read, but you see a lot of red, which is below 80%. You see some green, some districts are doing great. You can change this by looking at county if you wanted. And again, you can hover over, enter these entities and see their fully immunized rate as well as their student population and total number of schools. That gives you some context too, that some of these red counties don't have a ton of kids, don't have a ton of schools. And so any fluctuation in rates impacts them more greatly than others. If you look at the same measure for K through 12, you'll see it a lot more green. So for some reason, and we've tried to figure it out, and we're still trying to figure it out, kids become up to date with 2 doses of MMR as required for school entry, but they're not doing it when they're supposed to at kindergarten entry. They do great with the childcare, with that 1 dose requirement, and something happens between that childcare and kindergarten entry that, again, we're trying to figure out and address. Okay, did that. Okay.
Available by district as well?
Yeah, that was actually the first. Yeah, we could look at districts too for K through 12 for MMR. Again, you can do this for any of the reportable vaccines. Also looks really green, right? You can also change your metric to look at exemptions, which can also be enlightening.
What if a school isn't on there? What does it mean?
If a school is not on there, like Moffett, they didn't report.
Okay.
When you're looking at you said there's a gap, right, between preschool childcare to kindergarten.
Mm-hmm.
Are you looking at all at kids that maybe didn't go to preschool or have childcare?
Well, we're looking at preschool aged kids.
Right. But
So
we wouldn't be reporting if we're not going to preschool or childcare. And so when you hit kindergarten, they may not be up to date. And so I'm curious if that might be part of that gap.
Could be. Yeah, I don't know that we've considered that. We've looked at insurance status, we've looked at race and ethnicity, we're looking at distance traveled from home to clinic, things like that, using SIS data, not using school data, because we don't know who these kids are, because we get de-identified data. I'm going to go back to my slides.
Sorry, human services coming back. This is going to happen.
And again, these are just screenshots of what I've shown you included in your slides. So some takeaway from this particular data source: overall, among K through 12 schools, rates for 4 of the 5 required vaccines are over 94%, which is right where we want them to be for protection and community immunity. Among child cares, the coverage rates remain stable from last year, and they were all above 90%. This third bullet is what concerns us, I think, the most, is that for kindergartners, rates fell for 4 of the 5 required vaccines, including MMR, Hep B, polio, and chickenpox. And this next bullet is what is really driving a lot of our strategic priority, is that the MMR rates dropped by over 1% from last year, when Colorado was ranked as the last state in the nation. So we're currently sitting at 87.4% up-to-date rate for MMR in Colorado. And coverage rates in some areas are just too low to protect communities from outbreaks. So because we can drill down to the school and facility level, we can see that some of these facilities are below 20% for being up to date, with others at 100%. Yes.
Turk has an excellent point. We have a lot of children up in Eagle County, for instance, who don't go to a child care facility that would report, or don't go to, or go down to the trailer down the street where grandma's taking care of 10 kids and they're not reporting. So that could be a big difference between when the kids show up, those kids show up at kindergarten, they hadn't been reported under the childcare. So there's a gap of children not reported.
Yeah, I think that's a great point. There's also something that just occurred to me is that if you're not in a kind of a institutionalized childcare, then you're not accustomed to having to provide proof of immunization for your kid every 2 months sometimes. So yeah, I think that's a really valid point.
They are in CIS. I mean, we've captured that they've been immunized. It's just you're not reporting by a provider that's a parent or a friend or a neighbor.
Right. And we don't, within CIS, we don't know school enrollment or childcare enrollment or non-enrollment. And so we couldn't use CIS data, which really is our most complete data source, to drill down to that level.
Well, and this may be kind of an aside, but I'm also curious. You pull from CIS that they're vaccinated, but again, if they're not going to a daycare that requires a vaccination, they may not be up to date on, and that could just be an education piece, like still go get your kids vaccinated. But if people aren't being kind of, I don't want to say forced, but encouraged to do that as part of school enrollment, they're going to be behind as soon as they hit kindergarten anyway, right? Because it requires the two vaccinations. So they're already going to be lagging because they weren't required to get that first one to go to preschool.
You're hoping that if they're getting well child exams, and this is an access to care issue, right, that the physician or medical provider is talking to them about the immunization schedule at every visit. So if they're not getting those, I think that's another place we see them fall through the cracks.
And you had a question also?
Yeah, my question was, are schools not required to report? Is it not mandatory for the schools that aren't listed?
Like you said, Moffitt's not on
Oh,
there.
no, they were required to report. And that's why we put them on the map, showing that they didn't do what was required by rule.
So there aren't any enforcement teeth. So the Board of Health put that in rule just a few years ago. So we had a ramp up period. So then I think the question really is, everyone has had an opportunity to now embed it in their system. So what do we want to take it to the next level to get it there?
Send them a letter? Or?
Right. Yeah. Board of Health is keen on writing letters today. So I'm just saying. Why not? Yeah.
Is that the strategy?
So I do think in terms of, and I think Diana will get to this when she talks about the executive order, if this is about increasing that reporting, and then where my mind was going based on the board feedback from this quadrant over here particularly. And so when we articulated that reporting requirement, we actually started it with like an all, and then we backed it off to those baby facilities to say, okay, if it's 10 kids or less, but maybe that needs to be revisited as part of our analysis. And in particular, I'm wondering about an overlay of family childcare homes at CDHS with an overlay of our data set to say, are we seeing where we have high family childcare homes and high exemption or a higher miss of getting the right? That's just that data driven, right?
Well, it even seems like I was looking at my child's school, which is a kindergarten through 8th grade. They're not on there. I mean, that's probably 400 or 500 kids, but they're not reporting. So I'm like, yeah, those bigger schools really ought to.
And that's actually
Nasty gram for-
one of the rationale behind sharing it with parents too. Because if I were a parent, last year, my kid's childcare didn't report either. And so I had a conversation with them. I was like, what are you doing? So facilitating that kind of conversation between parents who want to see that information made public and schools can help drive us a little farther too.
You got a letter saying they were full next year.
No, we're safe.
So Deb, one note too is that local public health does interact with non-home-based childcares, but does not with the home-based childcares.
Right.
There's another disconnect.
Right. And there are a number of places where that family child care home carve out creates an oddity, from Clean Indoor Act to other things. And so it is just something to know that might be an area. And I'm looking at Lynn, so, just channel the answer up to the folks at the table. But I want to say that we actually had the legislation that did mandate it from the schools, and that the schools came back and the legislation didn't pass. And this was like many years ago. And then the temperature sort of got a little bit more even, and the Board of Health had the authority for us to do it in rules. So I do think in terms of that curve of that mandated reporting, we sort of started with needing it to be a bit of a push. So 80% was a success, doesn't mean it's a success today. That fair?
Legislation from 2014.
Yeah.
That required schools and childcares to make their immunization and exemption rates publicly available upon request. And then we took that into the rule and said, report that to us. We're going to put it on a website and make it easier for everybody to view that data in a single consolidated place versus them having to deal with multiple requests for the same data throughout the year.
In addition to the reporting requirement, there's also huge issues around data quality. And as a former technologist with the Denver School District, one of the most difficult places that I had with my team in being able to provide those accurate reports was specifically around this data, because the data entry for some reason was incredibly complex. Is there any push to help these reporting agencies do some data quality? And then as a data geek, one of the things that you noticed with your Gold Hill example, that 0.06% had to be one kid.
Probably.
Isn't there some sort of a reporting cutoff? I know that we had to exclude categories when they got down to, you don't have the kid named there, but particularly, I know like around race and ethnicity, that it was very clear that there was a minimum cutoff. Doesn't that exist with this data?
I think that exists at the facility level. And I think that we're supposed to suppress numbers less than 10. And I don't know what Park Hill's enrollment is, but valid point. Back to your data quality question. So a lot of schools and increasingly a number of childcare centers use SIS to look up immunization status, which does give them that, is this dose valid or not, answer. And this fall, will be rolling out new functionality for K through 12 schools that will allow them to, if they make an enrollment happen between their students and SIS, they can run a canned report and see who meets school requirements. And then that can feed into the aggregate reporting that they do for us annually. We're working on a separate childcare requirement or enhancement that will be very similar to the school one, which will come next year, because it is complicated. And sometimes you don't have a clinical person who is looking at those records, and then you have someone just counting doses and saying, yep, kid's good, when in fact the kid is not fully immunized.
Where doses were entered and it just didn't line up and we couldn't figure it out.
Yeah, the nice thing about all of the districts that are sending data electronically is that we can actually run that data through our SIS forecasting and evaluation engine and determine validity that way. And so the more districts we can get to send electronically, the more we'll get to where we can actually say something about an overall state rate, not just vaccine specific rates for Colorado students.
All right.
Okay.
Real quick, can I just ask a quick question? I think along the same lines of data, I think the same problem is encountered at primary care clinics where, you need to have somebody who's definitely entering the data, but with the indigent and all underserved that go to different clinics, sometimes they don't have somebody to verify and SIS, because while the clinic system reports to SIS, SIS doesn't report to the system, right? So sometimes they just take the word of the person who says, oh yeah, we have all our immunizations, sometimes without verifying, because they don't have the resources to go into SIS and verify.
I'm sure that exists for a lot of clinics. I also know that many, many clinics do look up SIS.
Yes, I'm not
separate
saying,
from their
but I know
EHR.
that some don't have the resources.
Sure, I get that. And there are hundreds of clinics, that send data bidirectionally to us. So they send a query to us, and then we send the whole immunization record back to them. That's where we want to get all of our electronic reporters. And we have hundreds of clinics that are doing that right now. So they don't have to access SIS separately from their EHR. I'm going to jump to this and then I'm going to pass it to Diana. This slide just compares rates across the 3 data sources that we've looked at. So that first section is about MMR, and you'll see that the rates can vary. The big thing I want to point out in this slide is that sample sizes mean something. And so a lot of weight is given to NIS every year, but we need to take that, I think, with a grain of salt. I think you can say more about CIS data because we know about validity of doses, that I put more stock into the CIS rates than I do into NIS rates. And the very last bucket down there is exemption rates. So we don't capture those in NIS. And we have very limited exemption data in CIS because it's optional for parents to submit that data to us. So I've just kind of pulled out the preschool and childcare, kindergarten, K through 12 exemption rates, because you can see that discrepancy between kindergarten and the others.
Okay. So with all of that data, that leads us to actually doing something where we have some room for improvement. So between the department and the governor's office, we have made raising immunization rates, and particularly our kindergarten MMR rate, a priority. And this really ties in nicely with the governor's priority on healthcare, saving people money on healthcare. Vaccines are a really great way to prevent disease, and it's cheaper to get somebody vaccinated than to actually have to deal with the disease, potentially be hospitalized, potentially be out of work, et cetera. So it is a very cost-effective tool to saving people money on healthcare and keeping people healthy in general. And so with the governor's strategic priority around saving people money on healthcare, that kind of dovetails down into some work that we're doing at the department level to improve vaccination rates. And so we have an executive order that came out just in June, where the governor's office was giving several directives to the state health department, and then a couple of things to our sister agency at HCPF. To look at different projects and initiatives that can help improve our immunization rates. And so I'll talk a little bit about kind of what the executive order says and how that dovetails specifically with our individual wildly important goal, our WIG, around immunizations. And you can see up here, we have a pretty lofty goal over the next year and then over the next 4 years, specifically focusing in where we think we have the most room for improvement. And so that's that MMR rate related to kindergartners. For some reason, we start off really great with the first dose of MMR with those little kids, and then we drop around 6 or 7 or so percentage points down to 87.4% for our kindergarten MMR rate. And so our goal over the next year, so if we look at the total enrolled kindergartners for this year, we're going to try and get that rate up to 90% over the next year. And that translates to 1,669 kids, which may not seem like a lot, but that's a lot. It's a lot of additional kids to try and get that extra MMR dose. And then our long-term goal is to get that up to 95% to hit that Healthy People 2020 goal. So we've got these 3 strategies here that are outlined in our wildly important goal. And then we've got a whole number of activities, some of which there's kind of cross initiatives between the executive order and what we've said we're going to do in our strategic plan over the next year. So this is a very high level snapshot, and you can I wanted to show kind of where we've got some synergy between what the governor's office is asking us to focus on and then things that we are planning on doing in our strategic plan specifically. So between our executive order and the strategic plan, we've got a number of these initiatives, and then there are some additional activities that I don't have listed here, but that I can just talk about really briefly as well. One of the things that we are going to focus on is studying the views of vaccine hesitant parents. So we did a really limited internet panel survey of just shy of 700 parents that identified as vaccine hesitant in some way. And so we're trying to look at that information and understand, like, what are their concerns? Do they have other barriers that we're not aware of? Is it just issues with hesitancy and they just have questions, about safety or timing of doses, or is it also potentially an access issue? And that's one of the things that we did see in the wee little bit of data that we collected is roughly about a third of the parents that completed that survey, we sort of put them in the ambassador bucket. They always plan to vaccinate on time, don't really have any questions relative to vaccine safety or anything. And then we've got another bucket of around 65% of those parents that had questions in some way, shape, or form. So what's interesting out of that is out of the 65% bucket, about half of those still said that they either vaccinated their kid on time or intend to vaccinate their child on time. So that leaves around a third out of all the parents that we included in the survey that consider themselves hesitant, have some questions, and don't intend to vaccinate on time for some reason, or are maybe on a delayed schedule. And so we've taken that information and then developed some messaging to try and reach those parents in a way that's going to kind of meet them where they are in a non-judgmental way, trying to talk to them about safety and importance of vaccination. We want to take that and go a step further and actually be able to do sort of a follow-up survey where we could survey a broader bucket of parents and then actually maybe be able to generalize that to our state. We just didn't collect enough information this first time to be able to say statewide, here's kind of what our snapshot is in terms of vaccine hesitancy. So we've got that as a project coming up. Should we be able to get some additional funds to do that work? What that leads into is, I know, just a little plug. But that leads into a lot of other things. You know, that's just one thing that we're focusing on, but it leads into a lot of other projects and work that we're doing. We're doing a lot of outreach and education initiatives. So we're having a lot of conversations with our local public health agencies to work with them and understand, like, what are they seeing in their community and what do they feel like is really their issue? Is it an issue of access? Do they feel like there are not enough immunizing providers? Do people have to drive too far to potentially get to a clinic? Or is it an issue of hesitancy and maybe some misinformation? And so we're really trying to work with local public health. They know their communities better than we do, and try and identify some strategies and interventions that we could implement locally with them, in concert with them. And so, you know, in talking with one particular county, they do think hesitancy and misinformation about vaccines is their issue. And so we're going to focus on that in that particular county. Whereas we've had conversations with others where they think access is an issue because parents have to drive over a mountain pass to actually get to a vaccine clinic. And so what are some things that we could do to help them maybe offer additional immunization clinics in more remote areas? Could they do maybe mobile clinics to reach people where they are? So there's a lot of those conversations are going on right now with a variety of local public health agencies. Hi.
You know, the one thing I don't see there, and maybe it's in your plan but not just listed on this priority, is outreach to providers, to the doctor's offices or the person in that office that does the care coordination for their.
Yeah, that's in the develop and implement the public health detailing piece.
Okay.
Yeah. So we totally agree with you. You know, one of the things that little nuggets that we got from this internet panel survey we did of vaccine hesitant parents is no matter sort of where they sat in terms of vaccines, their healthcare provider was still their most trusted source for information about vaccines, and whether they vaccinate or not. That's their doctor, their nurse, their healthcare provider came to the top. And so one of the things that we're working on, you know, taking that messaging, the tested messaging that we've done is we've developed some toolkits to give to providers. Our idea would be messaging that they're hearing publicly, potentially from us or from their local public health agency, would be similar to the messaging that they're also hearing from their provider, so that they can have those important conversations with parents about vaccines and be able to adequately answer their questions that they may have about vaccination.
Are there any providers that are immunization hesitant? Is that what you called them? Like, are there pediatricians that advocate for things like, I mean, is it acceptable? Is it?
Well, you know, in our organization, you know, because specifically Combo 7 is one of our strategic indicators. And I was just looking at our data because it's, you know, my CEO always tells me what's going on, right? And I said, but it's a lot of it is at least we're not getting feedback from providers. We have actually a focus group's going to look at it next week because it's a big indicator for us, is that some of them are saying that it's getting, even though we're an integrated system, getting access to care because to finish up those immunizations specifically for the combo 7 is because there's so multiple visits. And for us, if you miss key visits, you can't make up the vaccine, the whole combo 7. And so that throws it off. And so we're trying to figure out ways how to improve that, similar to what you're trying to do in that regard. Because like I said, I was just comparing our rates to your rates. We'll go up there in the computer. So, but for us, we're thinking it's at least access issue, even within our own system, with all these multiple visits. And then once you miss, like I said, once you miss one of the series, it throws you off for catch up.
A couple of the urban counties that we've spoken with, it does seem surprising for, in an urban county that you might have access issues, but they're seeing that.
Yeah.
In some counties, it's not just a rural issue.
Because it's like 6 visits. I mean, it's a ton of visits.
It is a lot, and it's a lot to keep up with. So in continuing, to work with our LPHAs, we're trying to partner with them on some initiatives to help them raise their immunization rates. So we're trying to give them data so that they know where all of their schools are in terms of, this is all in terms of the MMR vaccine in the kindergarten rate. Give them some data so that they know where their schools are, where they might be able to make some gains, do some additional outreach in their community. But then we're also trying to give them some additional tools and best practices. So if there's an initiative that worked really well in County A, should County B consider implementing that in their jurisdiction? And so we're trying to give them some additional information and see what we can do to, sorry for the pun, move the needle this year with the existing resources that we have. So we're doing our best, and we're having lots of conversations with those folks as well. We're going to be doing some additional outreach to schools, encourage them, to look at their kindergarten MMR rate, let people know, about the immunization requirements, maybe where they could go to get vaccines. And so those are a lot of conversations that we're still continuing to have. With schools and local public health as well as providers. There are a couple of things here denoted in the executive order that we are going to have to come back to you guys on specifically. So that's that third and fourth item, proposed to the board the increased use of standardized, easy to print medical and non-medical exemption forms. That's directly from our executive order. Our game plan is to come before the board later this year with a proposal. September, I believe, is when we were coming back for our request for rulemaking, and then November for a rulemaking specifically around the medical and non-medical exemption forms. And then this fourth one, proposing to the board that it better align Colorado immunization practices with national best practices recommended by ACIP. That's much more detailed and a much heavier lift for us. We have a lot of research and data gathering to do. There are 5 vaccines off the routine schedule that we don't currently require for school entry. Flu, rota, hepatitis A, HPV, and meninge are the 5 that we are going to be looking at, as well as the precautions and contraindications that are recommended by ACIP. That's not something we've ever brought before the board before, so we've got some research and data gathering to do around that. I'm actually not sure who was here a couple of years ago when we brought meningococcal vaccine before the board a few years ago. We're going to follow a similar process that we did that time, where we brought you a fact sheet around specifically around our disease burden and our information around the vaccine and our vaccination rates. And then we did some stakeholder engagement and outreach and got a variety of feedback, and then brought back a recommendation based off of all of that information. And so our tentative timeline is to get those fact sheets back to for each of the 5 vaccines that we don't currently require, as well as precautions and contraindications. Bring that back to you before the end of the year, for the end of 2019. It'll take us a couple of months to do the stakeholder engagement. That's a lot of meetings and coordination, and we want to bring in a neutral third-party facilitator, like we did last time, to lead those meetings. And so then we will gather that feedback and then come before you April, May-ish or so of 2020 for a request for rulemaking, whatever our recommendation is based off of that outreach. Next one, annually implement public education and outreach campaign. We are in the process of trying to find funding to be able to do a public outreach campaign using some of the messaging that we've got developed. The outreach that we're doing specific with healthcare providers, we do have that ready now and those toolkits developed. So we're going to be sending those out coming up soon. But to do a broader kind of public campaign with media and those kind of components are really expensive. So we're looking for funding to do that.
Just with constraints of time, I want to have all of our butts in seats. I see Webb's here. My favorite Webb is here at 1:30 so that we can get to our health equity conversation before it gets away from us. So I mentioned before I've got a bit of a time constraint, and I know Ms. Hammond does as well. So if I'm going to turn over to Executive Director Ryan Hunsaker, for her question, and then if you could wrap up in the next few minutes, that'd be great.
And just because I have the mic, I'll take the opportunity to thank the immunization program, Tony Capello, Division Director, former President of the State Board of Health. They have been so incredibly responsive to state legislators, to the governor, being very strategic around this issue and providing awesome technical assistance. So I'm really excited about where we're heading. My question, when I first saw some proposed messaging that came out of your formative research with the marketing company, they had, I am forgetting the figure and I'm hoping you can provide it. They had this counter that you could put on Facebook or something that showed the number of anti-vaccine messages worldwide that had gone out to social media. I'm assuming that was real. It was like millions or maybe even billions. Do you know what I'm talking about? Because I was shocked. I'm like, wow, if they're getting those types of messages constantly and public health isn't really out there giving the opposite, like no wonder, right?
Yeah, definitely. Tony Capello, for the record, Division Director. Yeah, that's correct. One of the things—
Can't speak, sir, until I call on you.
Oh, Mr. President.
Just a little too long.
You're going to be formal now with me. Okay. Yeah, one of the things that they proposed was a misinformation tracker. And that's something that this digital campaign will have a lot of different aspects, or could have a lot of different aspects to it. But one of them was at a social media campaign where even going to our website, we would be able to have that where they actually can track a lot of the misinformation that's out there and then actually go to some of those links and whatever. They're still ironing some of that out. But yeah, it just goes to show the name of the campaign is Spread the Vax Facts. And that's really what it's going to be focused on, is actually putting something out there. It'll be the first campaign in the nation that actually puts out an I would say an anti-vax, an anti message that says, no, this is actually what's true. And this is actually what's real. And did you know, like walking down the airport, there was a great one that's walking down, says, if somebody sneezes here, the measles virus can travel all the way to gate 38 and you can be infected 3 days later, right? And so people are like, and they're walking along this trail like, holy cow, is this for real? And the sneeze. So there's a lot of really creative aspects, but we do hope, and we will know that local public health will take advantage of this. I have a really strong feeling this will be taken nationally. I think other state health departments will take this from us as well. Like I said, it's going to be the first of its kind across the nation. And so we're pretty excited. But like Diana said, we are looking for additional funding to help make it the best bang for the buck.
A great question.
Oh, thanks.
Thank you, Dr.
Okay, so just very briefly, a couple of the other projects that we're going to be working with on is around that access lens and working with HCPF. And so looking to make sure that as much as possible, Medicaid providers, they're reporting data to CIS and are also part of our Vaccines for Children program. So that is a federal entitlement program that provides free vaccines to kiddos that qualify. We do have some Medicaid providers that are not part of our VFC program, so we want to look at that and see what we can do to ensure that they're part of that program. And then also do some work around, Medicaid providers that are billing for well child visits, but not for immunizations. If for some reason they're not actually providing vaccines, can we get them to provide those vaccines? We've got some other work that we're doing just in terms of access. So we're looking at where somebody might live versus their distance from an immunizing provider. Is that a long distance away? Do they have to travel more than 30 minutes? So trying to do some of that analysis and give that information to our local public health agencies so they would be able to know if there's potentially that sort of access issue within their county. Publicizing our school and childcare data. So we have a lot of data, lots of school and childcare data. And we're getting more and more people onto the site and looking at it. We want to continue to push that so parents have that data set if that's something that their decisions. A couple of the other things that are not on this list, we're going to be doing some education around emancipated adolescents, 15 and older. They are able to consent to their own vaccination. We want to make sure that folks know that that is out there and that they have a right to consent to their own vaccines if they're emancipated and 15 or older. We're doing some investigation about whether a two-generation approach, so this is kind of going back to the DHS, they have a similar model with care and patients and clients that they serve. Is that something that is feasible in terms of vaccination? Can somebody go to a clinic and mom get their flu shot as well as their child? We know that happens in some circumstances, like in the Kaiser system. You can go in and mom and baby can get a flu shot. Is that something that we could expand upon into other venues? So that's something that we're looking at. We're going to be doing some piloting of a reminder recall. And so that's identifying kids that are either coming due or overdue for a particular vaccine. So we're going to focus in on kindergarten MMR, and we're going to use CIS as our source of data. It's our most complete source. And so we're going to do some piloting of centralized reminder recall out of CIS in a couple of urban and rural counties. And then you've already talked about the CIS functionality. And then we're going to be looking at, policies and coming before you around forms and other sorts of things. So I will leave it there. We have a lot of projects in flight and a lot of things going on at the same time. So we're trying our hardest to meet this goal. So thank you.
What's the software platform that you used for your online super awesome compare this to that and pull this up? And I mean, it's just fantastic.
For the school and childcare?
Is that Tableau?
Yeah, that's built in Tableau.
It is Tableau? Thank you. That was a lot of really, really good information. Thank you both very much for being here today. Any last minute quick questions or comments? All right, seeing none. Thank you again very much for being here. All right, so our regular board meeting is hereby adjourned. What happened?
It's 1:27.
At 1:27, and we'll take a few-minute break, and then where are we heading?
Right back here. We're
And
gonna
we'll stay here.
and
Terrific.
Just boogie through until 2. I think we can get it done. That's awesome.
Great. Thank you all very much.
I don't want to take your time shifting around, so I think we should just try to plow through.